but good morning. On behalf of Texas Doctors for Social Responsibility and the Texas Patient Safety Initiative, I would like to welcome you all to our first ever Texas Maternal Mortality and Morbidity webinar. The discussion we're having today is vital. It's about understanding the challenges, identifying gaps, and finding actionable solutions to improve outcomes for mothers in Texas. Our speakers and panelists have a wealth of knowledge and experience, and I am very excited to know that their insights will make a huge impact. Each presentation will be followed up with a Q&A session during which you can pop your questions in the chat and they'll be presented to our speakers. Thank you again for joining us today. And with that, we will get right into it. Just a few housekeeping things related to financial disclosures. We are making this event eligible for CME credits, so just letting you know that none of the members of our planning committee had any financial disclosures. Most of our faculty did not have financial disclosures as well, barring one exception, and all of these will be made available for you to take a look at later. Just a few statements regarding continuing education and just an information for you. We will be emailing you within the next 30 to 45 days, and you'll have information about how to obtain those credits. So hopping right into it, I would like to introduce Evelyn Delgado, who will be delivering our opening remarks. Evelyn is CEO of Healthy Futures for Texas, a statewide organization with staff located in Dallas, Austin, San Antonio, Houston, and the Rio Grande Valley. Healthy Futures aims to improve the development of strong families through equitable access to sexual health education, preventative health care, contraception, and resources. Evelyn is chair of the Texas Women's Healthcare Coalition, an advocacy organization with 88 member organizations that advocate for access to preventative health care for Texas women. She serves on the American College of Obstetricians and Gynecologists District 11 Council, the Texas Medical Association's Committee on Medicaid, CHIP, and the Uninsured, and the Texas Collaborative for Healthy Mothers and Babies. Evelyn has extensive experience as a senior-level executive leader in public health at the Texas Department of State Health Services, including overseeing family and community health programs. And with that, I will pass it on to Evelyn.
Thank you, Yumna. And thank you all for joining us today. This is such an important topic that it's been important for years, and the work that needs to be done in this area of maternal mortality and morbidity continues to be so much needed. And I'm going to start out with just some background information and to kind of lay the foundation for the rest of the rich discussions that we're going to have today. So across the country, moms are dying at high rates with a disproportionately high impact on women of color. We've seen this in the media. We've seen it in the legislature, addressing the legislature. This is not new news. Based on CDC data, Black women are 2 to 3 times more likely to die due to pregnancy complications than white women. Again, nothing new. The Texas Maternal Mortality and Morbidity Task Force strongly states that the loss of one mother is one too many, and that is so true. Hence the need for us to really continue to focus on this work. The Maternal Mortality and Morbidity Review Committee was originally created as a task force in 2013 by the legislature. And then in 2019, it was changed from task force to Mortality and Morbidity Review Committee, which aligned better with the Federal Maternal Deaths Act and the name that was given for this kind of work in other states. So the work is funded by the state. So Department of State Health Services runs this work, oversees it, and it's funded through federal Title V funding as well as state funding. And then in 2019, the CDC awarded a grant to Texas to continue this work to enhance the review and surveillance that they were doing. Back in 2013 is when I was serving as Associate Commissioner of Family and Community Health Services. And so when the bill was passed to create this task force, at the time it was a task force, it fell to our division to create the task force. And that entails setting up systems and identifying applicants to serve on the task force, because it named various disciplines that needed to be on the task force. The review committee is a 23-member multidisciplinary panel, and they're charged with reviewing records of pregnancy-related deaths and root causes. So this is the core information that's available to advocacy organizations, to health-serving organizations throughout the state. In September 1st of each even-numbered year, they're supposed to, create a report publicly what their findings have been. They review cases of pregnancy-related death. They review trends, rates, and disparities, and severe maternal morbidity. They also review health conditions and factors that disproportionately affect the most at-risk populations. And then the review committee is supposed to look at best practices from other states to see if they can share experiences and systems and approaches to improving health in women. They're supposed to also look at pregnancy-related death based on the mother's socioeconomic status, because despite despite other topics where sometimes a lot of the health outcomes depend on socioeconomic status, what we have found is that whether you're white, black, low economic, high economic, low education, high education, whatever, the pregnancy-related deaths are not, they do not differ based on the mother's socioeconomic status. The committee's also to determine the feasibility of reviewing severe morbidity cases. We weren't sure in Texas whether there was going to be the capacity to be able to review the death cases as well as the severe morbidity cases. They had several findings, important findings, and I'll go over these real quickly, but these kinds of topics will be addressed throughout the webinar. So 44% of the reviewed pregnancy-associated deaths from 2019 anyway were pregnancy-related. Most pregnancy-related deaths were preventable, and this is one of the biggest findings that I feel is important to our community organizations that are serving women or that are in clinics or in social work, in mental health, in any number of arenas. The MMMRC determines a pregnancy-related death was preventable if they find that there was at least some chance of averting the death. It could have been a systems change. It could have been a policy within the organization. It could have been, basically in the community, awareness of services or not. There's any number of factors that contribute to these pregnancy-related deaths being preventable. Some of these are hospital-based, and there are separate other efforts in the hospitals, quality improvement efforts being done to address some of these things. The Texas Collaborative for Healthy Mothers and Babies is very involved in some of this work also, especially with the hospitals. Another finding was that 6 underlying causes of death accounted for 79% of all reviewed cases of pregnancy-related deaths. Things from obstetric hemorrhage to mental health conditions, embolisms, injury, cardiovascular conditions, infection, etc. Another finding was that multiple underlying causes contributed to reviewed pregnancy-related deaths caused by obstetric hemorrhage. Another example of where the hospitals are trying to address some of these through their quality improvement initiatives. Obesity, mental disorders, discrimination, and substance use disorder each contributed to pregnancy-related death, and violence contributed to pregnancy-related death. Violent pregnancy-related deaths, this one I was originally surprised way back when we started this work. With the manner of death or suicide or homicide represented 27% of pregnancy-related death. I know in our large cities, especially in Texas, Harris County, Tarrant, San Antonio, etc., they're identifying that domestic violence is a major concern in their cities. And the cities have implemented either task forces or have funded people in the city or county systems to help address violence, in particular domestic violence. Another finding was that a complex interaction of factors and characteristics contribute to preventable death. So it's not always a one issue thing that contributed to the death. Disparities persist in maternal mortality, with non-Black Hispanic women being most disproportionately impacted. So I know that in the past few years, and I've been happy to see that a lot of organizations, grassroots and advocacy organizations that are primarily Black women led and Black women serving have sprung up and have really taken up a big space in the prevention world. And I hope to see that continue. Another finding was that the enhanced maternal mortality ratio remained relatively stable from 2013 to current. And that's bothersome, that's concerning, because a lot of work has been done since back in 2013. And we would hope to have seen dramatic changes over time. And Finding number 10, which is the last one, is that demographic and geographic disparities in severe maternal morbidity rates related to in-hospital deliveries persist. So those that are experiencing the most severe maternal and morbidity rates are non-Black Hispanic women, women without a private payer for coverage for delivery, women with a 12th grade education or less, and women with advanced maternal age. And this is for severe maternal morbidity. So I'm going to close with the recommendations that the review committee made. They recommended increasing access to comprehensive health services from preconception through the postpartum year, engaging and supporting Black women, raising awareness with urgent maternal warning signs, healthy behaviors, and preventive services, ensuring access to behavioral health care, improving statewide infrastructure and programs to address violence and intimate partner violence, and prioritizing continuing education, diversification, and capacity of the maternal health force. These recommendations are big. They're not a one organization type of answer. These recommendations require really everyone in the state who has a part in serving women and families to look at what they can do to help with these outcomes that we persistently see in Texas. So with that, I'm going to turn it over back to Yumna. Thank you, Yumna. And we'll go from there.
Thank you so much, Evelyn. We are so lucky to have you today. And with that, I would like to introduce our very first speaker this morning, Mr. Ted Fox. Ted Fox is the founder and leader of the Texas Patient Safety Initiative and retired healthcare CEO with extensive experience in the nonprofit sector. A dynamic, visionary, and meticulous leader, Ted has made significant contributions to health systems and public hospitals. His expertise spans community health improvement, operational efficiency, safety and quality improvement, and change management. His career reflects a profound commitment to improving healthcare systems, fostering community health, and mentoring the next generation of healthcare professionals. Notably, Ted has also spoken extensively on Texas maternal mortality at both the San Antonio TEDx Convention and at Trinity University. And with that, I will pass it on to Ted Fox. I don't think we can quite hear you, Mr. Fox. You might have to unmute yourself.
How's that?
Much better.
Okay. Well, we'll find out if people want me muted or unmuted. Okay. I'd like to thank Yumna, first of all, for organizing this important webinar. This is a very, very important subject and a tenacious and problematic one. So we're going to examine how we're doing nationally, and then focus in on Texas and compare with other states. And some of the indicators, we rival so-called third world countries and compare poorly with others. So I'm going to ask for your help in requesting and demanding that our state officials do better. So let's begin. Let's see here, Yumna. Okay. This is our vision and mission for the Texas Patient Safety Index initiative. It's a consensus of the members, and we also have a set of values to how we will behave in pursuing our vision and mission. These are pictures of women who are no longer alive, who died of maternal mortality, leaving children and spouses and other family members mourning and behind. This is Michelle and Chris and her baby, Zavala. She noticed during her first weekend home a swollen foot, but the swelling resolved. She was told not to worry about it when she called her doc. And then 8 days after birth, she went to an urgent care because of tunnel vision and feeling like she was going to faint. And the nurse called for assistance and chest compressions and intubation, but it was too late. A week after having her daughter in a routine um, labor and delivery, she died of preventable pulmonary embolus at 35 years old. Very, very sad. This is another mom who has died here in Texas, Kira Johnson. She went to a hospital for a routine C-section and then complained of abdominal pain after a procedure. She begged the staff to address her symptoms and run tests. A CT was ordered but didn't happen. And after 10 hours of response without pain, without response from the medical team, they finally took her to surgery and found 3 liters of blood in her abdomen because her bladder had been lacerated during surgery and she'd been bleeding internally. She died on the operating table. By the way, 3 times as many African American women than Caucasian women die in childbirth. Um, we'll see some data about that. Some conditions make these tragic deaths possible. And let's see how badly we're doing, how poorly we compare. We're frequently a world and a national cellar dweller here in Texas. There's a mortality cascade where a lack of insurance dictates a lack of access, which means you don't end up getting necessary care. And then people die of treatable illnesses. And one of those is maternal mortality and morbidity. A key indicator is health insurance coverage, which dictates whether or not people can access health care, including prevention. We are 34th out of 35 nations in the Organization for Economic Cooperation and Development for having health care insurance. And Texas uninsured is the worst in the US. By the way, Texas was one of a minority of states to reject the Affordable Care Act's expanded federal Medicaid dollars. That would have brought in $10 billion over 10 years. As we posit, less insurance is less access, and you end up foregoing necessary care such as prenatal care. And you see here the Texas uninsured rate and the US and the Massachusetts for comparison. Texas is 51st in uninsured rate. If you can't afford health insurance, you usually can't get or afford health care unless you have a medical emergency or in active labor. And even that during this whole abortion thing is beginning to fall apart. You end up having to forego necessary medical care that you need due to its cost. Over a third of our national population is foregoing needed medical care due to costs. And Texas, once again, is almost the worst state in the nation. And thank God for Mississippi. You see in the bar graph there. When you're forced to go necessary medical care, you have deaths. Yeah, people are dying from conditions that could have been treated and their lives saved. This is called mortality amenable to healthcare. And once again, our country fares very poorly, ranking 26th among the OECD nations. And Texas is one of the worst states in the nation at 38th in deaths that could have been prevented by receiving healthcare services in a more timely basis. Then you have unnecessary deaths or mortality that could have been prevented, as I said, in a timely and appropriate healthcare if you'd received that. Looking specifically at women's care, how is Texas doing? Now, this is national. You see the United States compared with Sweden in this slide. The Texas overall national rank in reproductive and women's health is 49th. This is a recent data from the Commonwealth Fund. And remember, if you forego necessary care such as prenatal care, you have preventable deaths. So Vermont has 11% of women did not receive early prenatal care. Texas and Florida, 29%. Texas women begin prenatal care later. You can see in this slide that that's problematic. And why is that happening? Because the state of Texas didn't take free dollars from the federal government to expand Medicaid. The biggest driver of prenatal delays is lack of insurance in Texas. Women can't sign up for Medicaid until they find out they're pregnant, and because nearly half the births are unplanned, this often doesn't happen until the second or third month. And you see here the births that are financed by Medicaid in 2021, with Texas being a leading state of that. So it really has an impact on prenatal care and on maternal mortality. There are also Texas maternity care deserts. This is also due to Texas not taking the free Medicaid expansion dollars. More than 2 million women of childbearing age live in maternity care deserts. That's over 1,000 counties that have no hospital offering OB care, no birth center, no OB providers. And you see the figures here for babies that are born in maternity care deserts, and also limited access to maternity care in other counties. We also live in a rare country where women don't have federal maternity leave, which leads to problems. We recently saw the state approve CHIP coverage for over a year postpartum, and hopefully our postpartum mortality will improve. You see here national data about the pregnancy-related deaths during postpartum, and you see it's significant. This is a picture of just some different countries and what they do as far as giving moms support after delivery. You see there's some very robust things set up, and typically in the United States, that is not happening, at least in Texas. Now, the U.S. is the only high-income country, the OECD countries, that does not guarantee all mothers paid parental leave, although 13 states and the DC have introduced some mandatory paid leave from 6 to 12 weeks. We also stand as the only high-income country where there is no federally mandated paid leave policy. Here showing that what the birth rate or the mortality rate is in different countries, and it's very, very, very problematic. I mean, I guess I had difficulty trying to get the Texas mortality rates and morbidity rates, but I did get this from the U.S. for the U.S. mortality from the National Center for Health Stats, and our U.S. maternal mortality is almost twice that of 3 years ago, the mortality rate. So we are not heading in the right direction. U.S. maternal mortality is the highest in Mississippi. Texas is not doing well, and California is the national leader in terms of maternal mortality. And look a little later to see why that is. Here you have the U.S. having the highest maternal death rate, with the rate for Black women being by far the highest of any group. And uh, uh, Evelyn, you heard mention that also. Um, the lack of basic health care can have deadly consequences for women throughout the U.S. and especially for our Texas women. The U.S. is tied with Iran for 48th in the world, and is one of the few countries where maternal mortality is actually increasing, and the only developed nation. In Texas, our maternal mortality is shameful and scandalous. As you can see from the dark blue color, that we are among the worst states in the United States. The Texas maternal, I had trouble chasing down reliable figures for the Texas state maternal mortality rate. And so here you see some projections, but it did increase from 18.6 in 2010 to 38.7 in 2012, and then declined to 32.5 in 2015. So we are not heading in a good direction in Texas. Here is the California maternal mortality rate. It dropped by almost half, or 50% in 5 years, from 14% to 7.3%. Quite a dramatic change, and something that we'll talk a little bit about why that's happening. The U.S. has an unacceptably high mortality rate, and it's getting worse. The latest data from the CDC shows that mortality increased significantly between 28 and 21, topping out at the highest recorded rate since the agency began tracking it more than 30 years ago. All-cause mortality rates for pregnant and recently pregnant women increased from the U.S. from 2015 to 2019, according to a UTSA study. And racial and ethnic disparities in mortality among recently pregnant women are evident by cause of death, and you see here. A specific example, Serena Williams had a very scary childbirth story, and what it says about medical treatment of Black women. She had a blood clot in her lungs, and they needed to insert a filter in her veins. She interviewed in Variety magazine, and uh, she had symptoms of blood clotting. She coughed so hard that her stitches burst. She had to go back into surgery. She told her nurse, "I need to have a CAT scan of my lungs bilaterally, and I need to be on a heparin drip." They said, "I think all this medicine is making you talk crazy." So discounted her as a Black woman. Now, I'm telling you, I need a scan immediately, and I need it to be done with dye. I guess the name of the dye that she said was wrong, and she told her that she just needed rest. She fought hard and ended up getting the CT scan. So the doctor ordered it, and it turned out she had a blood clot in her lungs. They needed to insert a filter in her lungs in her veins to break up the clot before it reached her heart. So we've tallied up the casualty rate. Now let's look at what's being done about them in Texas. You see that the Black causes of infant death is almost 2.4 times that of the white infant death rates. So what's been done or is being done about this in Texas and California? In Texas, our elected officials gutted the funding for women's health clinics, causing the closure of 80 clinics. Our politicians refused $10 billion from the federal government to expand Medicaid health insurance for our low-income residents. And our legislature decided the maternal mortality problem needed to be studied by a task force. The bill title for the legislation setting up the the Mortality and Morbidity Task Force, said that it's relating to the creation of a task force to study, not to decrease, but to study maternal mortality and severe maternal morbidity. And we continue to study the problem. So Texas has destroyed the funding for low-income women's health clinic services, a closure of 80 of them. They have banned abortion and put Texas women and infants at risk, and we'll see more about that later. They've refused Medicaid expansion dollars, $100 billion over 10 years. And they established a task force, as I mentioned, to study the issue. Currently, there are 118 women dead, 200 children without a mother, only a percentage of the death toll in Texas. And these are the recommendations that and Evelyn actually went through these, so I won't belabor the point. These recommendations are very soft. We know that women are dying, and it's nice that we're getting into the weeds of why, but we need to work on a tangible response to this. If you have goals, they have to be measurable. They have the goals of the task force are extremely soft and do not appear to help as far as reducing our maternal mortality. How do you know you've engaged the Black community when you talk about improving that? How's that being measured, et cetera? So be specific, be quantifiable, know when you're making a difference or not. One of the things that the Texas OBGYNs recommends is the AIM patient safety bundles. And these are very specific. And this is a good start in terms of protocols or bundles for OB hemorrhage and severe hypertension, et cetera, et cetera. You see here that. So that would help if all of the hospitals in Texas and all of the OBs in Texas would be complying with this and using this. Here are the real effects, by the way, of the Texas abortion ban. Emergency room has, you see here an example, refused to treat pregnant women, leaving them to miscarry in a lobby bathroom. An abortion rights horror story explains a new reality for some American women, specifically in Texas. The 5 causes, their infant deaths after Texas, the ban on abortion in early pregnancy was associated with unexpected increases in infant and neonatal deaths in Texas, and congenital anomalies, which are leading causes of infant death, increased in Texas, but not in the rest of the U.S. It's the law of unintended consequences. So it's bringing about infant deaths, notwithstanding the intent of the abortion ban in Texas to save the lives of children, eventual children. The Texas Maternal Mortality Task Force, by the way, hasn't counted abortion death cases in Texas for 10 years. And the committee members discovered that long time omission this year. There is a doctor who recently was appointed to the committee, Ingrid Skop, who said that 9-year-olds can safely give birth. She was appointed to the Maternal Mortality Committee, 9-year-old children, I should say. And she also, if you will, has had some literature withdrawn. She was a co-author on a study, longitudinal cohort study of emergency ER utilization following mifepristone chemical and surgical abortions. And one of the figures lead to an inaccurate 2 and 3 lead to an inaccurate conclusion. Also, in that same study that was withdrawn by the publisher, there are fundamental problems with the design of the study that were unjustified or incorrect factual assumptions, misleading presentation of the data. There was a lack of scientific rigor that invalidated the author's conclusions, and et cetera, et cetera. Not exactly a robust recommendation for a person joining the committee. Um, Again, the law of unintended consequences, maternal death rates in abortion restriction states are 62% higher than in states with greater abortion access. That's you see the numbers, and this is reported out in December 5th, 2023. This is the maternal deaths by birth for state abortion policy. And we see what Texas has done, probable consequences. So let's see what California actually has done. They decided that the health of their population and pregnant moms was important. They were the first state to establish an Obamacare marketplace or exchange. They did not slash women's health clinic funding. They did accept federal dollars and expand Medicaid, and they formed the California Maternal Quality Care Collaborative and frequently and concretely and effectively address some of the causes of maternal mortality. So they didn't gut the Planned Parenthood clinic funding. They accepted those Medicaid dollars and they put in place maternal quality improvement toolkits. These are extremely, what should I say, detailed and helpful. They also have drills and scenarios so that you can go in and into the room and have a drill, and everybody does what it is that they're supposed to do during that. And by the way, Kamala Harris, it was just announced yesterday, is spearheading an effort to decrease national maternal mortality. And the first thing they're going to do is require certain types of crash carts in the OB area. And you see the variety of things here. Reducing C-sections, responding to OB hemorrhage. And let me get into a little detail. Let me get into the weeds somewhat here. Let's see. This is the table of contents for the improving healthcare response to OB hemorrhage. It's a CMQCC quality improvement toolkit. And this is I mean, these are actual hard things that are being done that are having hard results and bringing the numbers down. They're very specific and there are definite roles. And let's take a look at the next. As you see here on the screen, there are very specific things that are being done in California that help with bringing down the maternal mortality rate. And this one here is for maternal hemorrhage. And the next slide, this is the group, the CMQCC in their website. I would urge everybody to I would urge everybody to log in to look at their things in it. You have to become a member, but that requires just putting in some information. There's no cost to it. And if we go back up, we can see what the results have been. Sorry to skip along here. Okay, these are the results specifically related to the implementation of these protocols and whatnot. So I think the results speak for themselves. And it's just very impressive. I think Kamala Harris has frankly gotten some of this information on the setup and whatnot from the work that's been done and the studies have happened by CMQCC. So, going back to how we started, again, there are some conditions that make these tragic deaths possible, and we've seen how poorly we're doing this mortality cascade, where a lack of health insurance becomes a lack of access, which means not care, illnesses, resulting in demonstrably in Texas increased maternal deaths. So what do we need to do as Texans? Number one, fill the Medicaid coverage gap. That money is desperately needed, particularly in rural areas in those OB deserts. Extend the Affordable Care Act, enhance marketplace premium subsidies that are set to expire in 2025 to help coverage, to get coverage for low income women. Expand CHIP coverage. That's something that has been done, and that's, kudos to the legislature for making that happen. Require all facilities and birthing personnel to adopt and comply with the Texas AIM patient safety bundles. And then when those are in place, it'll be a bit of a step further, but to require implementation and compliance of all facilities and birthing personnel to the California Maternal Quality Care Collaborative Maternal Quality Improvement Toolkits standards. And by the way, restore Planned Parenthood Women's Clinic funding. These are women who should be alive yet, pursuing their dreams, raising their children, and making their friends laugh. The Medicaid expansion would have helped in terms of preventing deaths and improving outcomes, and but that didn't happen because the governor refuses to apply for that. And the time is now. If we don't educate and demand better from our politicians and the task force, Texas women will continue to suffer deadly results. Our Texas wives and mothers and daughters and sisters and other women are at risk of dying from childbirth, and they certainly deserve better. So that's what I have. I know I went through a lot of information pretty quickly. Again, you'll be getting this information, so I'd like to open it up for questions or comments or observations now.
We actually have a couple of great questions in the chat. And just a reminder for everyone in attendance, if you do have a question, feel free to pop it in the chat and I will let our speakers know. The first question that we have is from Dr. Davenport. Can you speak to why Texas maternal mortality numbers are so difficult to access? I remember hearing that they were normalizing how they were calculated with how the rest of the country calculates them. This was around the time SB 8 passed.
Actually, there was 2 or 3 years ago, when the numbers were particularly horrible. The state of Texas changed their number, how they were going to count. I think the CDC counts from date of birth to like 45 days afterwards. And Texas decided to count them for a full year. I'm not sure of the reason for that. They said it was to pick up some more of the deaths, but so I really don't know. Evelyn, do you have any insights in terms of why it's so difficult to get your hands on reliable maternal mortality figures in Texas?
I don't know, Ted. I don't have that answer.
Okay, me either. But it's been difficult and challenging. Thank you for the question. I wish I did have an answer.
Another question we have is, this information is really impactful. Is there a way to present this in a way that is simplified and easy to digest for an average Texas voter?
I guess just a graph showing the difference between Texas and California. That is very striking, and maybe a couple graphs that would show how how poorly we're doing in comparison with the rest of the states in the country. So that might be helpful to put that out there.
I think the opportunities for Texas voters come in the way of any legislation that perhaps would affect the Maternal Mortality and Morbidity Review Committee, and also any access to care legislation, because access to care seems to be the underlying issue for most of these findings and recommendations of the committee.
The other thing is that I have little faith in this task force that Texas has set up. Their goals are very mushy. You don't see numbers in there saying we're going to improve this from 30% to 35% or vice versa. And when you can't count your work, your results, it's very difficult to tell if you're getting anything accomplished. There also are no deadlines for that. I mean, if those goals have been presented to me as a hospital CEO, I would have sent the planning committee back to the workshop to figure out, okay, how are we doing right now? And what do we need to improve to by when? And then we can put an action plan together to accomplish that. One of the things that this California Maternal Quality Care Collaborative was started by I believe Stanford, and they got they started working on that problem. Then they partnered with the state, and now you have Oregon is part of that collaborative, and I forget what other state. I think it might be. Well, I don't know. I don't want to say, but they've been able to get other states to join in as well. So I would not wait for this improvement committee or task force here in Texas. I would start to work on this myself if I were an OBGYN or a nurse, learning these protocols that California has in place or the AIM protocols, and agitate for working on those within your hospital and within your practice.
And speaking on AIM, we actually do have another question about that. Every hospital setting I've worked in has been using AIM for several years. Are there hospital systems in Texas that are not using them? If so, how is it possible now that maternal designation is a requirement?
I'm sorry, but I don't know the numbers and figures on the AIM status.
If I could interject,
Please.
211 of the 242, 244, something like that, hospitals are participating in Texas AIM. It is a totally voluntary initiative, and the Department of State Health Services leads that effort. Texas has actually been very strong at getting the number of hospitals that it has gotten to participate in AIM. Those are quality improvement initiatives aimed at the hospital. Department of State Health Services is the lead, but the Texas Collaborative for Healthy Mothers and Babies also participates in supporting that effort. The maternal health designation is a separate initiative that started many years ago, back in, oh my gosh, I want to say in 2015, maybe, when the policies and the approaches were being developed. Those are now required for Texas. Every hospital needs to step forward to get their review and identify their designation for maternal health. That effort initially was done by the Perinatal Advisory Committee, which is overseen by Health and Human Services Commission. The three, both Department of State Health Services, the Texas Collaborative for Healthy Mothers and Babies, and the Perinatal Advisory Committee, all are required by legislation to collaborate on their initiatives.
Thank you, Evelyn.
Mhm.
And I don't know exactly in terms of putting the rubber on the road how California differs from Texas, but you could see from the intervention that was started there, they dramatically decreased the maternal mortality in California. So I am caused to go back to when Hopkins was rolling out the what was one of the bundles that they put in place. I think a central line bundle because they had a lot of infections. And the problem was that the physicians rebelled and said, not only no, they said hell no. So the physician that was spearheading the bundle went to the hospital administration, and the administration then told nurses that they could not and would not participate in it's putting in a central line absent the physician compliance with all parts of that bundle. So that kind of brought things to a head and changed it and dramatically reduced the central line infections. So I don't know what's going on. It may be a cultural difference in California. I'm not real sure, but we see the evidence that they reduced their maternal mortality by 50% in California. And it was already a low number anyway, compared to Texas.
Every state, well, not every state, I should say. Many states have what's called a perinatal quality collaborative, a PQC. And in California, the PQC has been in place for many more years than the PQC in Texas. The Texas Collaborative for Healthy Mothers and Babies is considered the PQC in Texas. That's just additional information. California, we have Texas, I say we, Texas, have looked to California and to their experts and how their PQC operates to help identify ways that the Texas PQC can operate at its best.
Thank you so much. Thank you so much, Mr. Fox. Thank you, Evelyn. And with that, we'll wrap up our Q&A. And now I'd like to introduce our next speaker for today, Dr. Lisa Boyers. Dr. Boyers is an assistant professor in the Department of Psychiatry and Behavioral Sciences at the University of Texas Dell Medical School. She completed her psychiatry residency and fellowship at the Medical University of South Carolina, where she then built her expertise in perinatal and reproductive psychiatry. As director of the busy Women's Reproductive Behavioral Health Center at MUSC Outpatient Clinic, she fostered key relationships with obstetric practices that brought telehealth and MOUD to perinatal persons in rural South Carolina. She's been a key individual in the formation of South Carolina and Texas's first perinatal psychiatry access programs. In June of 2022, she joined faculty at Dell Medical School and has assembled a truly unique multidisciplinary behavioral health team embedded in a fetal care and NICU setting. This team provides trauma-informed care longitudinally for women throughout pregnancy and the postpartum year. And with that, I'll pass it on to Dr. Boyers. I'm so sorry, Dr. Boyers. I don't think we can hear you. I had to have you unmute.
Thank you. Pardon me. I appreciate the help. I said, good morning, folks. You know, it never gets more comfortable hearing yourself talk about your academic accolades. And I kind of wish that people would sometimes introduce me as, this is Lisa. She's a little bit clumsy. She also likes dogs. But no one has yet ever taken me up on that. I am delighted to be here with you guys today, and I'm going to share my screen with you folks, and then we're going to talk about perinatal mental health. Let me get to the start here. Okay. Oh, hold on. We're in the middle of my presentation. There we go. Okay. So we're going to talk a little bit today about perinatal mood and anxiety disorders. I know that we've got a pretty varied audience here. We've got a lot of trainees. We've also got some people who are further along in their professional lives. We're going to talk about perinatal mood and anxiety disorders, prevalence, screening, treatment. I'm going to try to cover a broad amount of information in a short amount of time. And so there's going to be some time at the end if there are questions about things that you didn't, that you wanted to hear more about, feel free to ask. I'm going to start out just by mentioning this is what we're going to cover. So I'm a perinatal and reproductive psychiatrist. Even within, I feel like I'm still, I still surprise myself whenever people go, "Oh, what is that?" And so I'll explain that to you. So for me, that means that I did my psychiatry residency, and then I did a fellowship year in perinatal and reproductive psychiatry. And mine was very heavily focused on perinatal. Reproductive psychiatrists can work all like in women throughout their entire lifespan. There are some people who may focus on more PMDD, some people who might focus more on reproductively aged women, like pregnancy, postpartum, persons who have miscarriages, things like that. That's where I spend a lot of my time right now. And also, like, you know, every woman will at some point again go through menopause. And so reproductive psychiatrists also work on the menopausal mood changes too. And so that's kind of what a reproductive or a perinatal and reproductive psychiatrist can mean. I spend my time, I'm here at the University of Texas in Austin, and I spend most of my time actually being a fetal care center and a NICU psychiatrist. So I work with parents who have an infant in the NICU, or moms and partners who have a complicated pregnancy in our fetal care center. I also work and love supervising and teaching our psychiatry residents. And then I am a psychiatric consultant for Texas's perinatal psychiatry access program. I can talk about that later if anyone's interested. Ours is called PeriPAN, Perinatal Psychiatry Access Network. We're going to spend just a little bit of time. I think I've got 1 or 2 slides talking about maternal mortality first. I know that from Ted, who just spoke with you guys talked a lot about maternal and infant mortality in Texas. So if we have anyone new, this will be new for you, and otherwise it'll be just a quick refresher before we get into maternal mental health. So in whenever we think about maternal mortality, and I think that Ted kind of talked about this as well, maternal mortality or maternal mortality ratio is the amount of deaths that take place during pregnancy and the 42 days after pregnancy, and the cause of death is thought to be related to the condition of pregnancy itself. Pregnancy-related mortality is that kind of same ratio, but the time span is wider. It's up to 1 year postpartum, and the cause of death is thought to be related to pregnancy. And then pregnancy-associated mortality, it's kind of all-cause mortality. And I think that our last speaker did a good job in talking about this. Sometimes the way that we define or don't define a maternal death as maybe being related to the condition of pregnancy can kind of affect our numbers. And so in these numbers, I think, are the most updated numbers that we have from the CDC. We know that just slightly in terms of when we're looking at pregnancy-related mortalities, when are those deaths taking place? Just over half of those deaths are taking place after delivery. And you've kind of got roughly a split of the other kind of half taking place during pregnancy or right around the couple of days around delivery. And whenever, let's see, and in terms of like where are the bulk of these deaths coming from, we've seen over the past couple of years nationwide and also individual states that suicide and drug overdose have really emerged as the #1 cause of pregnancy-related death. The CDC has said a couple years ago, I think maybe like 2 years ago, when I was giving this type of talk to audiences like this, the CDC had said every 2 out of 3 deaths is considered preventable. And whenever they updated these rates and numbers last year, they said now from the data they had that every 4 out of 5 deaths is considered preventable. From the Texas MMMRC, the Maternal Morbidity and Mortality Review Committee, they've said that from last year, whenever they could reconvene to look over the past year's maternal deaths, I believe they said that like 90% of the deaths in Texas that happened for moms during the pregnancy-related deaths were actually preventable. And I would certainly argue that 100% of deaths that are suicide and drug overdose related are considered preventable. I'll just briefly go over this because I know you guys heard about this. The United States has, for an industrialized nation, we have one of the highest maternal mortality ratios. This graph looks at 1987, goes all the way up to 2002, which I think it was just a month or two ago whenever we got our most updated maternal mortality ratio. And so the most updated number that we have is 22.3 deaths per 100,000 live births. And I'm not so sure if you guys can actually see where my mouse is, but like this number, this kind of, it reflects like things had been going up for quite some time, since obviously since the 1980s. And if we were able to extend this graph out further to the left, we would actually see that for years and decades, the maternal mortality ratio had been decreasing in the United States as we got better access to antibiotics, safer surgical techniques, that type of thing. But then since the 80s, it has really been going up. We, fi we finally see that in 2022, a return to pre-pandemic levels of our maternal mortality ratio. And certainly for some demographics, you can see I've got Black women over here and also women aged greater than 40. These deaths are even higher than the average. And then how does Texas compare? This statistic, I think it takes kind of the average of the past several years, but it's 22.3 for the US as a whole. Texas is 28.1. So Texas certainly isn't, we're not leading the charge here in a good way. I know that you guys heard about this a lot from the last presentation too. Okay, now we're going to get on to the meat of this talk, which is where we're going to talk about perinatal mood and anxiety disorders. So you heard me say a few moments ago that a reproductive psychiatrist, or a women's mental health psychiatrist, we can kind of span the whole gamut. And whenever we think of the hormonal events that take place in a woman's life, we can kind of see like three different categories. One of which is menarche, whenever women start to have that roughly monthly. I think I've got a little animation here. So around the time that women start having menstruation, we see these little lightning bolts here are hormones, if it wasn't obvious. And you see this hormonal fluctuation that happens roughly monthly. And that's when you can start to see the emergence of some things like PMS, or when it's really, really severe, PMDD, which is premenstrual dysphoric disorder, which is essentially really severe PMS. So you can see the emergence of that after women start to have menstrual cycles. And then as a woman goes further along in a timeline, there may be no pregnancies, there may be one pregnancy, there may be multiple pregnancies, but on this graph here, I've got just one. But that's where you can see also you can see things like postpartum depression, sort of also any perinatal mood or anxiety disorder. And it might happen in one pregnancy, but not others. It might not happen at all. But here in pregnancy, you've got really big hormonal fluctuations. If we think about pregnancy compared to the estrogen and progesterone hormonal fluctuations that happen during pregnancy, it's really, or during menstruation, it's really big here. And then moving further along in this age timeline, whenever women get into like their perimenopause transition, the 3 to 5 years prior to whenever they have their last menstrual period, which is what we kind of officially would call menopause, you get hormonal fluctuations again. Like hormones are in fluctuation, even if they're fluctuating down, but they can actually still be fluctuating a lot during that perimenopause transition. And again, people can have some mood changes. And so what this tells us is that our moods are very susceptible to hormones. And we'll talk about this again in a moment when we talk about risk factors, but people who you tend to carry kind of like that risk with you. If you are someone who had who had pretty significant PMS or even PMDD in your monthly menstrual cycle, that the fact that you are kind of really sensitive to hormones, you're not having greater hormonal fluctuation during your menstrual cycle, your body's just really in tune with it, or your mood is really in tune with these hormonal fluctuations, that actually puts you at a more likelihood to have perinatal mood and anxiety disorders during pregnancy. Same thing down the road whenever you get into perimenopause or your menopause transition. If you have been sensitive to hormonal fluctuations during your life, you tend to carry that with you through these different kind of like events. So I wanted to spend a few minutes kind of explaining that, because it really sets up why we experience, or why we can see exacerbations of different depressive or anxiety disorders. In brief, for perinatal mood and anxiety disorders, this kind of spans the entire psychiatric gamut. So this graph, we've got blue being the persons who are affected, and pardon me, I'm turning off my cell phone. And the more red color, that is persons who are unaffected. So here's the mood disorders, the ones that are more like depressive. Depressive are also like bipolar disorder, psychosis. And so some of the three big ones are things like baby blues, peripartum depression, or what you will often hear people say, and you'll hear me say this, postpartum depression, and postpartum psychosis. So baby blues is something that affects most women. So rather than considering baby blues that is something that is pathologic, we should actually consider baby blues as a normal part of the postpartum experience. Baby blues is what people can experience kind of within a day or two after delivery. It can, begin within a couple of days, maybe a week after delivery. It can last, it's transient. It lasts for maybe a week or two. And it can look a little bit like depression, but people are still able to function. It does not meet criteria for an actual depressive episode. People don't need formal or specific treatment for it. And most people will experience this postpartum. There is an error in the middle graph here. I apologize. This should say about 1 in 7 women experience postpartum depression. 1 in 5 is actually about 1 in 5 women will experience a perinatal mood and anxiety disorder or a maternal mental health condition, but it's actually about 1 in 7 or 20% of women who will experience postpartum depression. That's really common. And then we're going to dive into postpartum depression a little bit more, so I won't talk about that more here. And then postpartum psychosis, which I think I've got a slide on as well later. That's actually the most rare, thankfully so, of our perinatal mood and anxiety disorders. It is about 1 to 2 cases per 1,000 deliveries. It is quite rare. It is also quite serious. So you really want to be able to identify it and get women the help that they need. We're going to talk just a little bit about perinatal anxiety disorders before kind of going back into spending most of our time talking about the evaluation and treatment for postpartum depression. And so with perinatal anxiety disorders, I think that, it's only been relatively recently that I feel like we've been acknowledging the fact that it's not just all postpartum depression, that like because of the hormonal fluctuations that I spoke about earlier on, that that can also not only affect our mood as a part with respect to kind of like a depression sense, but also affect us anxiety wise. And anxiety can look a lot and look different in different people. It could be things like just, a generalized anxiety, panic, obsessive compulsive disorder, post-traumatic stress disorder. And again, here, the blue is women affected, that red color is women who are unaffected. What I want us to get a sense of is the fact that this is a lot more common than maybe we might have thought otherwise. I'm going to go back and talk about postpartum depression now. And I think I've got one. There we go. So in terms of, we're not going to spend a lot of time talking about this, but I think since we're talking about depression, it's important to say, like, whenever we say depression, what do we mean? In the DSM-5, which is, our Bible for diagnoses within, if you're a psychiatrist, the DSM-5 doesn't have a specific diagnosis called postpartum depression or peripartum depression. It is major depressive disorder with peripartum onset. There was a lot of debate whenever they released the new version of the DSM-5 back in, I think it was 2013 or 14. And so I'm interested to see whenever they make revisions, if they'll do anything to kind of highlight perinatal mood or maternal mental health conditions within the DSM-5. But when we're talking about postpartum depression, its symptoms look like depression. So we are seeing some combination of just depressed mood, decreased interest, a change in appetite, change in sleep patterns, change psychomotor agitation. So kind of like feeling really restless or kind of like moving quickly, or also sometimes whenever people are pretty depressed, they've got a more like a slowed movement, loss of energy, feelings of worthlessness or guilt, difficulty thinking, and then of course thoughts of wanting to end our life. In terms of the risk factors for persons for postpartum depression, the number one thing is the one that you see highlighted up here in gray. It's a personal history of mental health history, specifically with postpartum depression. For some people, like some of the folks that I see in clinic, it's their first time or they haven't been pregnant before. So we don't necessarily know that. So maybe something that might clue us in that we want to just hold this woman close and make sure that we evaluate them closely is maybe their own history, their own personal mental health history too, which can also be a risk factor. Different types of the next set of risk factors are just basically psychosocial stressors. And whenever you look at things like these are understandable stressors that I think can put anyone at risk for having a depressive episode. Coming from a low-income household, having relationship or partner conflict, inadequate support and caring for baby or family, and then also first-time or teen mothers. Teens in general, they have higher rates of depression than the at-large adult population. And so they carry this with them into pregnancy. Whenever we have teen mothers, they have higher rates of postpartum depression as well. Different types going further down, different types of medical problems, like actually any type of diabetes or any type of thyroid condition. So diabetes type 1, type 2, gestational diabetes, hyper or hypothyroidism have are risk factors for postpartum depression. And then some obstetric or neonatal outcomes. And by that, I mean moms of multiples, meaning if, a mom is carrying twins or triplets, whenever there's a NICU admission, that's certainly a big stressor. And that's one of the big populations that I work with. And then whenever there's complications, this is another population I work with, whenever there's complications in the pregnancy, birth process or with breastfeeding, those also can be risk factors for postpartum depression. And then we want to talk about the risks of untreated depression. This is generally when I'm talking about the risks of starting this medication versus this medication. I always make sure that I am educating either my patient or if I'm talking to populations who might be offering treatments for depression to them, to moms themselves one day, that we acknowledge the risk of untreated depression. Whenever I started to think of medicine in this way, it really changed the way that I approached everything. So whenever we think of risks from untreated depression, we can think of the risk of untreated maternal depression from mom, from the pregnancy or obstetric risk, and also risks for that infant and child. Whenever we look at that first category, so what's the risk for mom? And we know that there are higher rates of suicide attempts and suicide completion whenever there's untreated depression. That makes sense, right? We also know that there is increased risk for substance use, and this is any substance of abuse during pregnancy. So it could be things that are maybe legal but discouraged, things like alcohol or things like cigarettes, but also increased risk of things like pain medications or other substances, or marijuana, other substances that are illicit. And then also women are less likely to breastfeed. They're less likely to initiate breastfeed, and they're less likely to breastfeed for longer periods of time when there's untreated depression. Obstetrically, whenever we look at the pregnancy, we see higher infant and maternal mortality with untreated depression. And then the one that I like to highlight here is there is an increased risk of preterm birth. And what comes along with preterm birth is often low birth weight. If you got a baby who's born before 37 weeks, they're often not weighing as much as a baby who is born at term. And so that is a risk factor from untreated depression as well. Moving further down to the infant and child risks, we can see a whole things. Whenever I have a little bit more time, I actually have like a couple of slides on this, and I picked out a couple of these. But basically, from the point when baby is a couple of weeks old to all the time at 18, when an infant, or excuse me, when a child is theoretically becomes an adult, we can see some differences. We see impaired mother-infant bonding by 6 months of age. We see poorer communication skills for an infant who is 1 year of age when born to a mom who had untreated depression. And these children, I want to be clear, they can catch up with their peers. But we can see things like difficulty whenever child gets to sort of like school age with like emotional conduct. We see increased academic difficulties, and also a 7-fold increase risk in adolescent depression, or in depression by the time that that child is 18 years old. And I think it's important whenever we are thinking about offering a medication versus how we treat depression, to think about like, what are the risks also if we don't make any changes, or if that depression goes untreated during pregnancy. I talked a little bit about this in terms of populations that may be more vulnerable. I was talking about adolescents and how they have a higher rate of depression in the population at large, and so they carry that with them into pregnancy. Black women, because of a lot of inherent stressors that they have in general, and also when in our healthcare system, have higher rates of perinatal mood and anxiety disorders. They have higher rates of maternal and infant mortality. Persons with lower income, and also persons of color, and also women who experience perinatal loss. And the reason why I say that persons experiencing perinatal loss are vulnerable is that oftentimes if you have a miscarriage, or maybe an early infancy loss, you are, after your postpartum follow-up, you're really not going back to the doctor routinely. And I think in the next slide or two, I'm going to talk about screening, but those women, there are screening guidelines set out for pediatrician well visits, for OBGYN visits, and that often may not happen if you have a miscarriage, and you're not being followed up by your healthcare provider regularly. So I think that leads them to being vulnerable to having untreated maternal mental health conditions as well. I'm going to talk real briefly about postpartum psychosis, because I wanted to kind of finish up talking a little bit about perinatal mood disorders. But postpartum psychosis, like I said, I think this was my only slide on it. Yep, okay. Postpartum psychosis, you've got the little table on the left that has some symptoms of it. It tends to develop very quickly, meaning it can, meaning within kind of like a week or two after delivery, these women will start to develop some of these symptoms, and some of it may be like Suspiciousness, difficulty in letting maybe other people care for babies. Sometimes there's difficulty communicating or advocating for themselves. Whenever we can see more psychotic symptoms, people can be having like strange beliefs or delusions that also may veer into the territory of hallucinations. Sleep disturbance is something that every case of postpartum psychosis that I've seen, I've always seen a sleep disturbance as part of it, where basically these women are not able to get appropriate or adequate sleep. And the newborn time is already a time that can be difficult for sleep as well. And then you can kind of see some irritability, mood swings. So that's kind of some of the symptoms that you may see with postpartum psychosis in terms of who's at risk for postpartum psychosis. Again, the biggest one here, just like with the risk factors for postpartum depression, it's prior episodes of postpartum psychosis. And then also women with bipolar disorder. So bipolar disorder is probably the number one mental health condition that would put someone at risk for postpartum psychosis. That being said, most women who have bipolar disorder, thankfully, do not go on to develop postpartum psychosis. Remember, we said this was like 1 to 2 per 1,000 births in terms of the prevalence of this. Also, a family history of bipolar disorder. Sleep loss is a stressor, and also first-time moms. First-time moms are more at risk. Now I want to go to perinatal mood and anxiety disorder screening recommendations in general. So these two, all of these organizations that you see on the left-hand side, like US Preventative Task Force, WHO, ACOG, they agree that we should be screening women for depression and anxiety in pregnancy. And it's ACOG and the American Academy of Pediatrics who kind of gives us how, like when and how should we be screening these. So ACOG says during pregnancy, we should be screening women at least once during pregnancy, once postpartum, more as indicated. So usually this tends to happen at your initial prenatal screen, and then at your six-week postpartum follow-up. And then American Academy of Pediatrics says that we should be screening mothers at their baby's well child visit at the 1, 2, 4, and 6-month well child visit. And I just want to point out that, I don't know, it has been very recently that they acknowledge that we should be screening for anxiety at all because of how prevalent it is. Whenever I first started doing this, the recommendation was let's screen for depression, but there wasn't any guidance on screening for anxiety. And I'm really glad that they're now formally recommending to be screening for anxiety. In terms of what tools do we use for screening? There are two really common ones. I don't know how relevant this may be to this audience, but I just want to bring these up. A really common one that is used in general, like throughout general psychiatry, very often is called for depression, is called the PHQ-9, the Patient Health Questionnaire 9. It is 9 items long. It is available in any language for free. It takes 5 or less minutes to complete. It is sensitive and specific. You always want to review item 9 because that question asks about suicidality. And so you want to make sure if you're giving the screen to someone that you're not just looking at the score to say, is this a significant or not score, but that you're also specifically looking at the questions too. Another one that's really popular to use is called the EPDS, the Edinburgh Postnatal Depression Scale. This one was developed by an OBGYN across the pond in the UK in the 80s. And this is a 10-item questionnaire. Again, it's available for free in a lot of languages. You want to review the last question because that asks about suicidality. This one has just a couple of limitations. It's got some reverse scoring, which just means you have to basically be really mindful whenever you're scoring it. Some of the questions go, 0, 1, 2, 3 points being the highest, and some of them go reverse scoring. 3 points, 2 points, 1 points, 0 points. And so if you have humans scoring these, you just need to make sure that we're being conscious of that. There's also been a couple of studies that showed that that this was less valid in low or low middle income classes, and also because it was written in the UK. Some of the questions are just worded a little bit funny, and so sometimes people get a little bit caught up by it. But both of these, in general, the PHQ-9 and the EDPS, these are both reliable and valid tests to be used, and are the two most common ones that we use here. And for anxiety, I'm going to start with the one on the left. So if you're using that Edinburgh postnatal depression score, 3 of those questions in its questions item number 3, number 4, and number 5 on that questionnaire, they are specifically about anxiety, and you can use those as a reliable means to evaluate anxiety. And then if you're not using the EDPS, a good one to use is called the Generalized Anxiety Disorder 7 screening tool. It's a 7-item questionnaire. It is very quick and easy to use, and it's sensitive and specific. So these are generally the things that have the best evidence to be used when we're screening for depression and for anxiety. In terms of treatment, and I think I'm nearing the end of my time here, so I'm going to go a little bit quickly and ask questions if you have. Whenever we are at large thinking about treating depression and anxiety, this is kind of the main algorithm. If someone has pretty mild depressive or mild anxiety symptoms, whether or not it's, major depressive disorder, generalized anxiety, OCD, PTSD, if it's mild, that's whenever we generally try to prioritize therapy first, as opposed to medication management. Whenever it is moderate depression or anxiety, or especially severe depression and anxiety, that's whenever, in addition to getting someone into evidence-based like therapy, we also want to consider a medication to help lift that mood or bring that that anxiety kind of back into control, to bring someone into euthymia. And I think, let's see, whenever I am here, whenever I'm talking about therapies, we want to think about like we can think about medication management, which is obviously pharmacological, and the non-pharmacological medication management. These are the things that have evidence. So individual therapy. And whenever I say individual therapy, we want to think about what is evidence-based. Like, for instance, for PTSD, it's not just sending someone to a therapist and going, okay, get some therapy for PTSD. You want to make sure they're in evidence-based psychotherapy, which means things like EMDR. For depression, that would be, or EMDR, or like exposure and response prevention. For depression, that would be things like cognitive behavioral therapy, or a type of therapy called IPT. And so that's when I just wanted to be clear. And whenever I say therapy, I mean getting people into the right therapy for what they're experiencing. Group therapy also has wonderful evidence. Things like physical activity, exercise. There's a lot of really wonderful evidence starting to come out about yoga, because yoga employs mindfulness, which you see further down on the list, but it's also exercise, group therapy, and then there's some evidence for omega-3 fatty acids, and also for light therapy too. If you're interested about that, you can ask me about that a little bit later. And then the last piece of what I want to say is, whenever we're thinking about an antidepressant, we're oftentimes reaching for an SSRI, like a serotonin specific reuptake inhibitor. You're often using what has worked best before, because by and large, SSRIs are very compatible with pregnancy. In general, you want to keep someone on, let me get all these off. There we go. You want to have someone on the lowest dose of what keeps them well. You don't want to undertreat someone. You want to try to limit to as few medications as possible. I say this one where it says there's not evidence to support tapering a medication in the third trimester. That's something that sometimes it used to be. I haven't seen that as much proliferated as adequate treatment. But sometimes we used to say, okay, well, let's take a medication, but then stop it in the third trimester so that baby's not exposed to it whenever they're born. If that doesn't make sense, basically, then you just put someone at kind of risk of relapse right around delivery. And I mentioned you want to use the lowest effective dose, emphasis on effective, and you want to avoid like you want to use as few medications as needed, and sometimes it's one and sometimes it's two or three, but you want to use as few medications as possible to help keep mom well. I will Brexanolone and zuranolone are some really new treatments that just became available. Well, zuranolone, which is the oral form of brexanolone, these are basically they are allopregnanolone, which is a neuroactive steroid. We talked about how basically perinatal mood and anxiety disorders occur because of this hormonal fluctuation. These work on that pathway. We finally have got around to medications that kind of act on this hormonal pathway. That's what these medications are. One is administered via an IV, and one of them, zuranolone, is a medication taken by mouth, just like any other, like most other antidepressants that we think of, that's taken for 14 days, and they have really good evidence. Zuranolone became available about 6 months ago. And okay, all right, I wanted to make sure that I was here at the end of my slide. I'm just over a few minutes past 9:30, but wanted to be mindful of your time. I'm happy to take any questions that you guys have.
We actually have a couple of great questions in the chat already. The first one is, are there standard protocols used to determine if a maternal health death is related rather than a mental health death is related rather than associated with pregnancy?
I think that would be a really wonderful question for someone who's on the Maternal Morbidity and Mortality Review Committee. I applied for, but wasn't chosen to be on the Texas MMMRC. I was on the South Carolina MMMRC years ago. And at that time, they were just kind of getting smart to make the switch of thinking about mental health the same way that we think about on the same grounds as having equity with other medical illnesses. And so I don't know the answer to that about how it's evaluated in Texas, but it sounds like perhaps maybe one of our two other presenters might, if they have information to weigh in here, I would be happy to have them speak on that. But unfortunately, I don't know how that's evaluated.
And another question that we have is, I appreciate that you emphasize evidence-based therapy. Given this, it is difficult to find a therapist at all for patients in need, especially folks that are unfunded or federally funded, much less to find a therapist with specific evidence-based therapeutic approaches. Other than referring to county MH resources, do you have any other access suggestions for folks with funding?
I think that is such a, whoever made that comment, yes, it is incredibly difficult. All therapy is not created equal. And so, especially whenever it matters, we really do. We want to make sure that people are in evidence-based therapy. And I think one of the things that can help with this, especially if you're in, we're probably coming from all parts of Texas today. I'm here in Austin, which is it is a big city, and so I think especially in some of our more rural areas of Texas, of which a lot of Texas is, it is really difficult to think about finding a therapist. One thing that I am appreciative of, as far as it goes from the pandemic standpoint, if you can say that you're appreciative of something, is that we all got hip to telemedicine, right? So depending on your patient's abilities, like telemedicine has made therapy a little bit, and just healthcare more accessible to all of us. What I wanted to mention was things that places that can be really helpful for this is are the state perinatal access programs. So in Texas, ours is called PeriPAN. It's called Perinatal Psychiatry Access Network. If you're a child and adolescent psychiatrist, or if you're a child and adolescent health practitioner, you're taking care of children, there's also one called CPAN, the Child Psychiatry Access Network. And basically, these are organizations that PeriPAN takes care of the entire state of Texas. I work for the one here in like our southeast central area of Texas, but they've got PeriPANs all over that take care of the entire state of Texas, where basically if you are if you are taking care of a pregnant or postpartum woman, by taking care of, I mean any point, you could be a social worker, could be the midwife, the OBGYN, the pediatrician, where you're kind of indirectly maybe finding out about mom's mental health state. You could be in the allied health, which a lot of you are. So taking care of is a very broad definition, and you need help either getting that person into treatment or providing the treatment yourself. If you're like an OBGYN or a family medicine physician or something like that, where you might actually be providing this treatment yourself. Um, or if you need help with referrals, like we get calls from pediatricians where they did the PHQ-9 and the GAD-7, and they found out the mom is actually really struggling with anxiety, and they need to figure out how to get this mom into care. You can call your the PeriPAN, and I'll Google the number. I don't have it memorized offhand, but I'll take it up and put it in the chat. And basically, you can be connected to someone like me. And also I work with a team, and it'll route you to basically the closest hub for you, where you can ask medication questions. We can help refer a patient into care with a psychiatrist with reproductive training or experience. We can help that individual provider provide that medication management to that patient. And also we can help with referrals. And so we help with referrals, whether or not people are English speaking, have insurance, want to be in person, or prefer virtual care, and I don't know, all different types of situations and socioeconomic statuses and languages and things like that. And I think that basically PeriPAN can be a really helpful place. It is free to use too, and it's open Monday through Friday during business hours. And so I just want to make sure that folks know about that. I'll look up the number for it too. If you Google it, you'll find it, but I'll look up the number for it as well. Oh, and someone put it on there. Wonderful.
Another question that we had was, how can we ensure that our approach to treating perinatal mood disorders is culturally sensitive and ethically sound, since this can be a taboo and particularly difficult topic for many patients?
Again, very good question, and very true. I think that I think that we need to think about like trauma informed or trauma sensitive care. Even though like those national guidelines that I said mentioned just screening for depression and anxiety, like they don't make a comment about screening for different trauma. There are different screeners. We in psychiatry have screeners for everything, just like in medicine, we have screeners for everything. And so a lot of clinics or a lot of organizations actually argue that we should be screening like all, let's see, we're talking about, reproductively aged women right now, or pregnant women, pregnant and postpartum women right now. So I'll say that, but screening your patient not only for anxiety and depression, but also for maybe different traumas that they have experienced. And I would say that probably like any patient being cared for in any health situation can also be screened this way as well. There are a lot of different screeners. There are a lot of easy questionnaires where we can ask people just about what to kind of get a snapshot of what they have experienced in the past, what may be affecting them now, what are different circumstances that are important to know about them, and how they approach the healthcare system. And so I'd say that if you're not, if you find yourself in a working environment where that's not happening, figure out the person who is kind of either the clinic manager or in charge for that clinic, and start having those conversations about how we can be providing equitable care for all of the patients that we're seeing.
And we've got another one. It says since
Okay.
reproductive, yeah, you're popping. It says since reproductive psychiatry is a relatively new subspecialty, how would you advise medical students and other trainees to get involved early on? Any resources to use or programs to be aware of?
Yes, I think that is wonderful. I didn't know that reproductive psychiatry was a specialty till I got to fellowship, and I interview medical students, and I'm always so glad and pleased whenever they say, "I'm excited to meet with you because you're a reproductive psychiatrist." I'm interested in that too because I wasn't aware of that whenever I was going through medical school. So as far as there are, so if you in order to do this type of work, you don't have to do a fellowship like I did. I think you can if you decide like this is what I want to, this is like absolutely what I want to do. But um there are a couple of organizations that I can highly recommend. So just like if you want to immerse yourself in sort of like trainings and things like that, PSI, Postpartum Support International, they have a wonderful, they're a wonderful organization. They have an annual conference. They have little mini conferences. They also have a network specifically for students and trainees who are interested in this field. I think really highly of them. I've presented at a couple of their annual conferences. I think like that's a wonderful resource. Also, you can either look into the Marseille, it's MARCE, the Marseille Society, which is also related to NASPOG, which is the North America. Oh God, I'm forgetting my acronyms. So let's go with Marseille because I can't remember what NASPOG stands for. It's another like wonderful organization that has trainings, conferences, groups to be involved with. Now, on a like if you're already in your training, I think one really wonderful place to go that has a lot of information is the NCRP. It's a National Curriculum for Reproductive Psychiatry. Not everyone here is a psychiatrist, and that's completely okay. This is for psychiatrists or other healthcare professionals who are going to be working with pregnant, actually, who are just going to be working with reproductive age women. That spans the whole lifeline for, or age line for women's. And so the NCRP was created in 2019 to actually provide some training and for like, and some of them are kind of like PBLs, problem-based learnings that are done on a big group level. And some of them are also kind of like individual lessons or things or modules that you can pull up on your own and review. If you're really interested in PMDD, you can pull up kind of like the individual training case on PMDD or substance use or alcohol use disorder or OCD or trauma. And I think the NCRP is a wonderful resource for anyone who is a patient facing healthcare provider. And then if you are really interested in reproductive psychiatry, there are sometimes whenever, depending on if you're in, I don't know, medical school or PT school or PA school, whatever, what have you, there are different organizations that have like reproductive fellowships that you could consider, or also like kind of doing an away rotation if the university that you're at may not have like a very strong reproductive program, like reproductive mental health program, maybe doing an away rotation somewhere else, or looking at some of the academic institutions that you can get training at that do have a really strong institute. But I think Postpartum Support International is a wonderful resource. Marseille Society, and then the National Curriculum for Reproductive Psychiatry is a really wonderful training resource that I use a lot of the time with my residents and other trainees here.
And one more question for you. What future advancements or innovations in treatment and diagnosis do you foresee improving outcomes for mothers with perinatal mood disorders?
Oh, what a lovely question. I think that I'm so excited that I used to work at Medical University of South Carolina in Charleston, and we were involved in I know I talked about it really quickly, but we were involved in 2017, the brexanolone trials, which are these neuroactive steroids. You're basically, after delivery, people lose a bunch of estrogen, progesterone, because you don't need it for the pregnancy anymore. People are more likely to have, that's the most vulnerable time. And basically, you're giving people back this progesterone with brexanolone, and it was an IV infusion that was about like a 2.5-day infusion. Now with zuranolone, it's an oral medication. And I think that I was so excited whenever we were involved in that trial and you got to see it work. And it was random, it was placebo controlled. You didn't know who was getting it, but we always thought we knew who was getting it because the people who got the treatment, who we thought got the treatment, seemed to get better a lot. And so we were involved in both the brexanolone and the zuranolone trials, and I was so excited for both of those to come to market. Zuranolone, because it's an oral medication, you don't have to go to the hospital, you don't have to get an IV infusion, you don't have to have mom maybe be separated from family or baby for a couple of days while she's in the hospital getting an IV infusion. It's so much easier to obtain. I've had really good luck in terms of getting it approved by insurance companies and into the hands of moms. I think that like it was tough between 2019 when basically the RCTs, the trials ended for zuranolone actually, I guess it was like 2020, until, last year, or basically this year, whenever we were able to prescribe zuranolone. It was really hard knowing there was a wonderful treatment around, but it hadn't gotten through all the hoops to get there. And so I feel like neuroactive steroids are just going to change the way that we treat disorders in general. They're actually going to start doing those trials in adults, pregnant or not, male and female or otherwise. I think that neuroactive steroids have a positive impact on our mood. Those trials are already being done, and I imagine that that's where we might continue to see a lot of development go. And I'm really excited for that. But we're already in the point where I'm excited to be. So that's kind of a non-answered, but that's my answer to that question.
And I fibbed. We do have one very last question, and then I will
Sure.
let you wrap it up before our break. How can we advocate for better mental health support and resources within our healthcare systems to address perinatal mood disorders?
I think that this is how can we I think that this is similar to the other question that was asked about, basically in places where we do not have a lot of resources, how can we make sure that we're attending to maternal mental health conditions. And so I would say kind of similarly, I know that Mr. Fox, who presented before me, talked about how some of the data can be actually hard to find in certain places, but it is out there, whether it's our Texas-based statistics or our national statistics. But maternal mental health is it's not having a moment, it's having it's having this moments that has turned into that's turned into years, where there's a really big spotlight that has not moved off of it. And so I think so continuing to make sure that we keep the focus on what is 50% of our population, and continuing to have those conversations with people, advocating at your local level, at the state level, at the national level. If you're interested in making sure that maternal mental health is a part of the conversation, then I think it starts at places like this, where you're kind of getting a little bit of, you're getting some information, but then continuing to act on it. So get involved at your local levels, at your state levels, at the national levels, too. And some of those organizations that I mentioned, PSI, Marseille, they can kind of help with that as well.
Thank you so much, Dr. Boyers. Your enthusiasm is palpable. We're so glad to have you. Thank you. Thank you. And with that, I will actually transition us over into our break. We're going to take a quick 9 or so minute break. We'll be back promptly at 10 a.m. with our next speaker, Dr. Sampson. In the meantime, let your dog out, use the bathroom, grab a snack, and I will see you guys at 10 o'clock. Everyone, welcome back. We're sitting at 10 o'clock, so we'll go ahead and get right into it. I wanted to start us off by introducing our next speaker, Dr. McLean Sampson. Dr. Sampson is an associate professor at the University of Houston Graduate College of Social Work. Her published research focuses on factors that influence maternal mental and physical health. She's published articles on postpartum depression, home visiting intervention, racial and ethnic disparities of postpartum depression, and the use of motivational interviewing in healthcare. Effective interventions for maternal behavioral health continue to be a priority for Dr. Sampson as she develops her research agenda. Dr. Sampson is active in several community-engaged research projects. Currently, she is the principal investigator for the Department of Health and Human Service funded programs, GLOBE and UH Healthy Start. And with that, I will pass it on to Dr. Sampson.
Good morning, everyone. Let's see. So, trying to get back to my Zoom. Hold on just one sec, please. Okay, so good morning, everyone. I am a little bit scattered today because I am one of the 800,000 that still does not have power in Houston. So thank you, Allie, for being so organized and such a great communicator. And I ran over to a friend's house and presenting to you now. So just to tell you a little bit of background in case we don't know each other, I have been at the University of Houston Graduate College of Social Work as a professor since 2011. And when I first came there, I was very focused on behavioral health in medical settings. I have a real passion for trying to get social workers into medical settings so that we can screen and intervene for mental health issues to take that load off of the medical professionals who I know are already overbooked and don't have a lot of time. But I also have a passion for helping moms and women in general during times of pregnancy, birth, and postpartum. And I've been very focused on maternal health since I was pregnant with my first child back in 2005. And the reason I became so focused on maternal health is I noticed that when I moved through the various providers that you do when you're pregnant, from the OB-GYN to the pediatrician, sometimes there are other people called in, you know, like nurses, MAs, you're seeing all of these people and being poked and prodded. But the thing that I really noticed was nobody's asking about how I'm doing, the mom. Like the whole focus was on how the unborn baby was doing and how the birth was going to be. And when I asked my provider that, she said, well, my job is to make sure that you have a healthy birth. And it just really stood out to me about like, yes, exactly. So why aren't you focusing on the mom? Because as a social worker, I'm always aware that I stand in a place of privilege. And even in my privilege, I was very stressed out during my first pregnancy. I had just enrolled in the PhD program. This was an unplanned pregnancy. I was in a fairly new relationship. We did not have a lot of money. So I was very aware of like, wow, what are other women going through who have less financial privilege, don't have the white privilege, and nobody's checking on them, you know? And then when I became a new mom, I really became even more concerned that nobody was checking because you're so isolated when you first have your baby. People may come and visit, but as you know, if you've ever had a baby, you really are isolated in the dark hours when you're up feeding and you just have a lot of time to think. And it just seems like a very vulnerable time. So in fact, in research, it does show that, of course, this is a vulnerable time. How our health is during pregnancy affects how our health is in postpartum. It also really affects the health of the developing child. We know now that women who develop fatty liver, their babies are at more risk for a host of issues, which I can't recall right now because I've got Hurricane Beryl mind. But the point is that our mental health and our physical health is directly affecting the baby. And so I would love for us all the professions who see moms, in social work included, to really learn how to listen to moms and engage with them and ask if they have the supports that they need. So at University of Houston, I first developed an intervention to decrease postpartum depression symptoms among low-income moms. I wanted to do that through using somewhat, not really paraprofessionals. I think now we're using a lot of community health workers. A few years ago, that was not in fashion, actually. And I was calling people lay health workers because the women I was working with in the interventions that were funded were actual women who were volunteers in the community. So they didn't even have CHW training and education. So the way I did it is I would go to agencies that served pregnant and postpartum moms. I would ask if I could train their either employees or their volunteers on how to do this 7-step process of intervention. It's based on problem-solving tools. It's great for all rates of literacy. And one of my favorite things about it is it's very cheap to do, because I don't have to train mental health professionals. I can train community people to do it. And then those community people usually have more trust garnered in the community already. So I've done that intervention several times. The first one was at a Healthy Start program that was over in Sunnyside. And main out that I'm sure are, does depression change during or after pregnancy, depending on which phase she's in? Because that project actually took pregnant and postpartum moms. And I also measure self-efficacy. So self-efficacy is how competent do I feel to handle whatever stressors or tasks are in front of me? Because since I was pregnant, have had this theory that your self-efficacy really takes a major hit when you're pregnant, because first of all, you're going through a lot physically and mentally, but also our wisdom isn't really tapped into. We're really encouraged to listen to outside wisdom, the books, all these websites now that are teaching us about signs and symptoms and things to look out for, which is great, but it can become very overwhelming and you lose your own inner compass. So those are the two main outcomes that I studied there. I've done that intervention also nationally. I was funded by the Kellogg Foundation to do it in 5 different Spanish-speaking communities. So I actually did the training with a friend who is bilingual, and she helped make sure that the women who would then be going out into the community and speaking Spanish were using culturally relevant, linguistically competent words to engage and work with moms on depression. And so through that work, I was getting to do, direct effect of trying to encourage women's mental health. But through that work, I definitely saw and heard feedback that we can work all we want on a mom's mental health, but when she's in the midst of poverty, domestic violence, having a special needs child, being cut off from family because maybe she had immigrated here, fear of deportation, fear of being reported to CPS, all of these things were working in a constellation of risk factors. So I really was aware that we need to focus on trying to decrease barriers, right? Decrease barriers to optimal maternal mental health and physical health. So then in 2017, I joined the group that some of you might have been a part of that was in Houston. It was funded by Houston Endowment. And at the time it was called Improving Maternal Mortality and Morbidity, I think. And then it became Reducing Maternal Mortality and Morbidity. And it was such a great group to be a part of. It was really too bad when we had to disband. And in that group, there were a variety of professionals. There were MDs, there were nurses, there were a few doulas, but there were also people, philanthropists. There were also researchers like myself. There were teachers, there were academics, there was statisticians, which is very important. There were people from the state. So all of us were tasked with dividing and conquering, trying to figure out what was going on locally that was causing such disparity in maternal mortality. And since there were presenters ahead of me, and y'all are all experts as well, I'm sure you know that Houston is not exempt from this national crisis we have with maternal mortality and morbidity. And we know that women of color, Black women, especially locally, are suffering at about 3 times the rate. And with infant mortality, it can be as high as 5 times the rate for Black infants dying before their first birthday. So we know that this is a community and a population that needs focus immediately. And one thing I loved about that group was there was a qualitative component done by Kim Baker at UT Public Health, where they went out and asked moms and they asked providers, what do you think is going on with maternal health? Like, do you know about the risk? Do you know about the importance of prenatal care and postpartum? And then they were asking the providers, what barriers do you experience? And so they produced a great report that showed women were experiencing a lot of bias due to insurance status, race, ethnicity, I think even age, and that there was a big chasm between what the women knew to be their risk and what they knew to be what resources were available to them and what the providers knew was available to them. So everybody was frustrated. The providers were frustrated too that the women they were seeing that were on Medicaid were not entering prenatal care earlier. And then the women on Medicaid were frustrated that the wait time was so long and that there weren't enough providers available, and that some of the providers really were not pleasant during the interactions. And we also know from research that provider-patient interaction makes a huge difference on if the woman comes back for her next appointment and if she even follows the guidance and the advice. Because we all have to remember that pregnancy and childbirth was not meant to be done on an individual basis, right? Like, we are communal people and women are very community driven, and we listen to our moms, our sisters, our aunts. We listen to people who came before us about how to take care of our bodies and our health during pregnancy. So even though medical providers might be giving advice, it might be contrary to her family beliefs and her cultural beliefs, which is what all of my research has shown too, is that family and culture have a very big influence on decision making. And that if we as practitioners, whether we are social workers or medical providers, if we don't attend to that, it's pretty disrespectful, right? Like, it's not really meeting the client where they're supposed to be. You're creating a communication barrier between the two of you, because just like everybody that's human, we want to be seen and heard and valued. So if we don't ask about their family beliefs or religious beliefs about medication or birthing practices, we're missing a whole part of that individual. So this led me to knowing about the Healthy Start call for funding. And Healthy Start is a fantastic program that's been funded since the mid-'80s, even though every 4 years, Congress seems to have us waiting on the edge of our seat to see if it's going to be funded again. But it started as a demonstration project because the people who came up with the idea of how Healthy Start should be had this great idea that it needs to be community embedded and community driven. So Healthy Starts work to reduce the risk of maternal mortality, maternal morbidity, infant mortality, and infant morbidity by by funding programs that are in communities that have at least 1.5 times the national average of infant mortality. And in Houston, when you look at our rates, and in Texas, when you look at our rates of infant mortality, we appear to be about the national average, which I believe is now 5.5. It might have gone down a little bit. and that's out of 1,000. But when you disaggregate the data and you look at it by race, that's when you see that Black mothers and Black infants are dying and having lifelong injury at much higher rates. So getting back to Healthy Start, I thought, okay, I'm going to apply for this grant because I can do that as a professor. I think it's great to have it in the School of Social Work because Healthy Start really values the trend, trying to decrease the racial gaps and disparities. And I really wanted to have an infrastructure that would support that because I needed to really focus on one particular group to try to help make our small dent in reducing racial disparities. So I'm going to talk about Healthy Start now. And Allie didn't know this at the time, but so I had Healthy Start from 2019. No, wait, I don't even know what year it is anymore, y'all. I had it for 5 years. It was funded in 2019. It came up for refunding this spring, and we wrote an excellent application. We had an excellent program, as I'm about to show you. And for some reason, the funder, even though we had great feedback, the funder actually awarded it to Harris County Public Health. So I've also been in a period of grieving because, as you see, we had an amazing program and I had no indication that we would not receive the funding again. But the good news is that there is still a Healthy Start in Houston and Harris County. It's just being operated out of Harris County Public Health. And I think they're keeping the same name. So you'll hear about it. And luckily, this service is still here. So let's see if I can share this screen. Looks like I can. And then let me go. Okay, Allie, I can see you. Can you give me a thumbs up if you can see? Okay, great.
Yes, you're good.
Okay, so I kept the name simple. I just named it Healthy Start at University of Houston. And I think in here it's going to tell you the main goals of Healthy Start. There are currently about 101 across the United States. At the time of our funding, we had Houston, there was one in San Antonio, there were 2 in Dallas, there were 2 in, there were 2 in San Antonio, 2 in Dallas, 1 in Houston, and 1 in Tyler. Now, when they did this next round of funding, they did not refund one of the Dallas sites, but they did give one to a collective that's in Austin, which is a fantastic collective. I think it's called Maternal Health Equity, something another. They're going to do a great job. Okay. So what is Healthy Start? It is funded by the Health Resources Services Administration, HRSA. Great organization. I've also had other grants through HRSA. HRSA really tries to improve community health through service programs. So Healthy Start is absolutely a service program. It goes directly into the community, which is fantastic. A lot of these other block grants and things go to an agency which might have to divide up their funding and work on other programs. But with Healthy Start, I'm required to put all $5 million for 5 years towards trying to solve the problem. So the infant mortality has to be at least 1.5 times the national average. As I said, I guess as of 2023, there are about 111 healthy projects. So the 3 pillars that exist in Healthy Start, and they're still there for this round of funding, is they say, we want you to improve women's health. And you do that by having a core component of home visiting. So all Healthy Starts have to have a home visiting, but they don't all have to be the same curriculum. We used Growing Great Kids, which is also used by Healthy Families America. It's a wonderful program that is trauma-informed and uses a lot of trauma-informed strategies to bond with the mom. Because if any of you have worked with populations of moms who have been through systems like Child Protective and have been on Medicaid, they're very skeptical of working with outsiders. They're really tired of another program telling them they don't know how to parent or they aren't doing things right. So I loved Growing Great Kids because it's very respectful and treats people with dignity and treats them literacy appropriate ways to bond with your child. Like that we help them make dolls and do role plays. It's really cool. So we also educate about reproductive health care. We are motivated to try to get women into prenatal care as soon as possible. So even though we're in the community and my staff were social workers or CHW type of people, so they aren't medical professionals, they are calling them and saying, hey, do you have a health provider? If not, let me get you signed up. Are you on Medicaid? If not, let me get you signed up. We are the connectors. We're really there to try to do a circle of care where we try to get them in, get them connected to their appointments and get them to go to their appointments. And if they don't go, then we follow up and ask what barriers were there. We also were able to serve 100 dads. They encouraged us to reach out to dads. They did not have to be they didn't have to be partners of the women, but it was great because they had to be dads of a Healthy Start baby. So it was great to get some single dads enrolled and get them connected to healthcare and other social services resources. And then the third pillar, which was one of my favorites as a social worker, is you have to make larger impact than just the individual level. So all Healthy Starts are required to have what was called a community action network. And as Harris County's doing it, it'll be called a consortium. And the consortium has to have at least 25% of its members be Healthy Start participants. And I think they're pretty good about enforcing this. I'm not sure, but I wish all grant funded programs did this, where they enforce that community members have to have a say in how the program is going, because sure enough, we would hear feedback from them. Hey, y'all are using words we don't even know, right? Like, what do you mean by, let me think of a good example. Like, what is high risk? What does that mean? And what is postpartum depression? I don't have depression. I'm just stressed, right? So if you're constantly getting feedback from the community, we could change how we did our approaches. And we could also change how, even though we have some reports about infant mortality that are telling us that sleep issues are the #1 driver of infant mortality in Harris County, we could figure out like why, what's going on. Are y'all not hearing about what is safe sleep? Are you not doing it? And we learn that, in fact, a lot of women are listening to their grandmothers who are like, of course they can sleep on their stomach. That's what I did. So in other words, it's very important to have community involvement. I had a fantastic director, Lysandra Noyle. She oversaw the implementation of everything, and she had been a case manager. And then Laretha oversaw the case managers, and Brandy was out there in the community trying to make partnerships with Texas Children's Health and Legacy and all of the great community agencies that are providing medical care. And then Latasha Perry ran our Community Action Network. And then for our direct services, you can see we have case managers, and we had a fatherhood involvement person. And so the case managers are really taught to do holistic case management, meaning I want y'all to do a full biopsychosocial. Don't just ask about like prior pregnancies, which we do, and did you carry them to term, and have you terminated pregnancies before? But also, what's your housing situation? How safe do you feel at home? We did the ACEs. Do you have a history of trauma? Food security. We asked about that, so that from the beginning, these case managers could help them with finding housing, finding food. We got some supplemental funding along the way, and we're able to actually hire doulas and mental health people. So by the end of 5 years, I had this awesome integrated health program, which has always been a dream of mine, right? Where you have a case manager who's managing all aspects of this woman's care. And the case manager is able to know from the doula how the birth went. She's able to know from, we also had a nurse, Kim Thompson, who was great, or not Kim Thompson, I always say that, Kimberly Taylor Branch, who screened and intervened for high-risk moms. So she was talking to the women with high blood pressure. She was doing some interventions when they were told to go home and wait it out. She showed up when people had high blood pressure and sent them right back to the ER after trying to stabilize them. So it was great to have this holistic program. As you can see, there are several performance measures for Healthy Start. They really want everybody having health insurance. And we referred to Change Happens, which I know has a different name now, but they're excellent. Increase the women with reproductive life plan, increase postpartum visit, usual source of care. As you can see, we did screen for non-medical drivers like depression, IPV, father involvement. We know that makes a difference. In my dissertation, I actually, I did quantitative data. So it wasn't interviewing people with qualitative data. With the fragile families where they interview mom 48 hours after birth. And the number one impact that had on mom's mental health was emotional support from the father of the baby. Even if they weren't married, even if they kind of hated each other, it was her feeling supported by the father of the baby that buffered her stress and depression. Let's see what else. Okay, so I just want to share these highlights real quick that by 2023, we had served 842 people. And I always like to remind people that in 2019, we were funded. We enrolled one person by the end of the year because it took me forever to get staff and office and all of that you all probably are familiar with if you've ever run a program. And then in 2020, our friend COVID hit. So really these numbers happened with a lot of momentum in the last 2 years. 67% of the moms, babies, and fathers identified as Black. Half of all women served entered the program when they were pregnant, which is excellent. That's what Healthy Start wants. That's why it's called Healthy Start. They really want to start in pregnancy, but it's real hard to get pregnant women enrolled in prenatal care and in social services programs when A, if they don't know that they're pregnant, B, maybe they don't even have Medicaid until mid second trimester, and C, just the mistrust that's going on now with medical providers, but also social workers, right? Social services. We really have to spend a lot of time on the front end gaining trust. 80% of women received doula services. Any pregnant woman that came into our program was asked if she wanted to have a doula. Most of them said yes, and 100% were satisfied. We constantly did evaluations where our director, Lysandra, called people and asked some standardized questions about their satisfaction with the program and what else would they need. So doulas are amazing. They do need a lot of support. I'm always happy to talk about like our experience of having a program and then bringing in doulas who were not fully integrated into our program because they weren't there from the beginning. And doulas are already kind of like on the outside. They have mixed reactions from hospital workers. So I love talking about like lessons learned from that. I like to show this real quick too. We screened almost everybody for interpersonal violence. And the rates were, I think, about 1/3 that were experiencing interpersonal violence. We screened for depression. And one thing that I always find interesting is that you would think in a Healthy Start program, when women are coming in and they're living in communities which are experiencing high infant mortality, and that in Houston, that has really been highly correlated with low income as well, and being Black. And so you would think that the rates would be high for depression, but they weren't high when they came in. And we're still always trying to figure that out. Like, is it the screening tool? Is it the words we're using? Because then when we did focus groups with the mom, what we found out is that they really weren't identifying what they were experiencing as depression. They felt a lot of stress, chronic stress, and that was about to tip over into depression. And so they really benefited from having case management that kind of kept their levels pretty well. Anybody that was depressed, we referred them right away. Like I said, by the end, I had in-house mental health providers. So I was able to use grant money to pay those providers every time they saw a person. 60% of the babies received well baby visits. And we only sadly experienced one infant death in 5 years, which every death is a tragedy, obviously. But statistically, that is very good out of trying to do the math right now and I can't, but let's say at least 300 babies. Healthy Start babies, we were proud to see that our low birth weight among Healthy Start babies was only about 10.3% compared to the preterm birth rate. That should say, yeah, our preterm birth rate was better. So low birth weight isn't right. Our preterm birth rate was better at about 10% compared to the Houston average, which is almost 13%. And this is just some examples of us in the community. Let's see. So we also did some one-pagers because I was fortunate enough to have a fellowship with the Baker Institute at Rice University that really helped me bring together all that I was seeing and learning and turn things into one-pagers. We did a lot of advocacy for continued funding and had a lot of support from Sheila Jackson Lee and Sean Theory and other legislators. I mean, everybody cares about babies, right? So that's kind of the thing we go in with. We did increase our Instagram presence, which we're really excited about, and partnered with people like the Earth app. So I think it's about 10:30 and I can stop sharing this and open it up for questions now.
We actually have a question in the chat.
Sure.
You mentioned trust in providers and have done research on cultural beliefs about postpartum depression. How would you advise providers to navigate depression and other postpartum mood disorders effectively and with cultural competence in mind?
Yeah, I think that's a great question. And thank you for the curiosity, because I say that curiosity, really genuine curiosity, is the number one thing. And I know that doctors go into this profession to help people, and that your training really pressures kind of brings that out, or like, you don't have time sometimes. So what I advise is, I'm a huge fan of motivational interviewing. I can do trainings on motivational interviewing. I love training providers on how to quickly build rapport. And it's basically using open-ended questions. And I would start with, how are you doing, mama? Like really just taking and looking her in her eye and asking, how are you doing? And then if they're like, I'm fine, how are you really doing? Do you feel like you're getting the support you need? Who would you say is your biggest hype person right now? Do you have a hype person? Like kind of asking about their supports, and then that will give you clues. Who do they listen to? Is it family? Are they mentioning religion? So I think you go in kind of assessing about supports on a very individual, personal level, instead of like, here's a brochure for the food bank, here's a brochure for a counselor, because you don't know yet. And then people get offended that you're assuming that they don't have the support they need, right? So yeah, I think that motivational interviewing, I know we've had some implicit bias trainings, and I love learning about and teaching about implicit bias, but honestly, I think it still keeps us up in our head and takes out that human element of just slowing down and looking somebody in the eye and going, how are you doing? We got a lot going on. How are you doing during this power outage and being pregnant or having to breastfeed? How's your mental state? How's your stress? That's a great word. Stress is socially accepted everywhere, but depression is not socially accepted. It has a lot more stigma. Great question.
Another question we have is, how do programs like Globe and UH Healthy Start integrate community feedback and needs into their design and implementation?
Yeah. Okay. So here's an example of Healthy Start, and thank you for asking about Globe. Woohoo! That's the other program I had that when I was so busy with Healthy Start, I actually gave that program to somebody else at U of H, but it's still going strong. And it's training social work students to go work in medical settings. And where we get our client or patient feedback there is through the students. So honestly, that is one that it's going to be, and all programs are like this, it's affected by the PI. Does the PI, who I was the PI for these grants, actually listen and then write it into the next grant? So what I would do is I would be pretty crafty and say that our metrics had to involve, like our evaluation had to involve interviewing the people and getting feedback, the people who were served. So I'm trying to think when I wrote this, one thing we were going to do, and I'm hoping Healthy Start will enforce this, is for their consortium model, they said you have to hire somebody from the community with lived experience. And I think that that's, so there are two things that should happen, right? You should, I employed people with lived experience. As you noticed, all of the women that worked with Healthy Start were Black women, and most of them were from Houston. Almost all of them were moms, right? So they had mothers, sisters, or personal experience of going through the healthcare system and maternal morbidity and all that. So they had passion. But with the consortium, this next round, Harris County will be tasked with hiring somebody with lived experience, meaning they've been through it. And that's integrating what the women want. Because when we did focus groups, they told us, we want to hear from other women that have gone through this. And that's something I like to say when I have an audience is the disparity, I guess, in awareness and education is alarming. It's alarming. There are some women who have no idea that maternal mortality exists, and they definitely have no idea that their sisters, their Black sisters, are experiencing it at such high rates. People really still think it's just a one-off tragic event. So I think that they were telling us we want to see more representation. You know, another dream of mine has always been to do like a grassroots public a PSA where it's actual people from the communities, from the Latina communities, from the African American, from Asian, from white, doing kind of like testimonials and stories, right? About like how they felt trusted and seen and heard, and when they didn't, how they advocated and how they listened to their body. So they want more representation, and I suggest that you build that into your grants with having a community advisory board. And then how will you guys be held accountable for listening to the community advisory board? Because nothing burns down trust faster than community people telling you what they want and me not listening, right? I had to do real quick turnarounds too. It wasn't like, we'll do that in 5 years. Real quick turnarounds, right? Like, hey, y'all said you wanted this in the giveaway bags. We hear you, we'll put more breast pads in there, you know, and like telling them, I see you, I hear you, I'm going to do that. So I think you have to build it into your outcomes because the accountability to community has been pretty spotty in a lot of programs. I saw
Someone
some
mentioned
comment.
Someone mentioned, my experience has been that providers often have no clue about available support services.
Mm.
How are you educating providers about your programs?
Yes, yes. Um, that's so good because we experience two different things. We either go into clinics that are inundated, like they know they're like, we know y'all are always coming to talk to us, or they don't know anything. So again, it's these huge disparities. It's very interesting. And I like to tell people that my experience is providers are in the same boat as just consumers and everybody else in Houston. And in that, Houston is very fragmented, right? Like we have the world's largest medical center, yet these disparities. We have this huge support network of legacy and all these FQHCs, yet people can live 2 blocks and not know that they're near the Hope Clinic. So I think, again, it's a matter of universal education. I will tell you, too, that as many groups as I've sat on, every single group is like, do we have a resource book of like what resources are available? And then one reason that comes up that there's not a resource book is because they change. Like we had Healthy Start and we had our own partners. It's gone now. And so now we're scrambling to tell everybody like, okay, it'll be at Harris County and it'll be starting soon. But all of that to say, the onus is on us, right? We have to go out, and that's why I had a whole outreach manager. Is her job was to meet with at least 2 medical focused clinics that see the moms in the zip codes that we served and make sure that they're aware of Healthy Start and make sure that if y'all can just get them to Healthy Start, we'll take care of all that social services, referrals, and providers. But also, I would just love if we had some city level network, that was like a 311 situation, but it was only for maternal and infant health and resources, because there are some really amazing programs that are not the bigger FQHCs, but that we would find out over time. Houston's a very word of mouth place.
Another question we have is, can you share some of the successes and challenges you've encountered while working on the GLOBE program to increase the number of clinical behavioral health social workers?
Yes, yes. One of the biggest challenges was with what are they called now? Practicums. So in social work, you have to do something like 500 hours of going and doing a practicum at a placement. So with the GLOBE program, we had about 20 students a year, maybe 30 one year, where I tried to make sure each of them were in medical placements that have mental health and physical health. That's kind of how I watered down, like, it's good enough if it's a place that actually has like a warm handoff to mental health. One of the challenges was some places don't have somebody who's already there that's a LMSW or an LCSW, and we need that to be able to supervise the intern. So like I always tell the story that one of my favorite places to put social workers is healthcare for the homeless. But they used to have a social worker, and then he retired. And since then, we have not had a social work intern. And it drives me crazy because I see them and they see me and they'll be like, "Where's our intern?" I'm like, "We have to have somebody to supervise them." But if you're at a place where you want a social work intern, um, you can always email me, and then I email the practicum office, and they've become a lot more creative about like, how can we get a liaison, like somebody offsite to do that? But the demand is there. And I know that the doctors want that help. They need help, right? It's more about the supervision, but we can arrange for that. The Graduate College of Social Work can take care of that. And also, PS, I don't know if you've heard, UH Downtown is starting a master's in social work program. So they now have bachelor's level people who do internships. But frankly, in the bachelor's level, you aren't learning a lot about clinical assessment, just to be honest. And then in the master's level, there will be another program. So social work interns are an amazing resource.
We've got another one. What policy changes or systemic improvements do you believe are necessary to better support maternal mental health and reduce maternal mortality rates?
Mm-hmm. I mean, I'm just such a believer of things happening in the community. You have to, I'm still shocked at the disparity of awareness and community and how cut off people can be when they are not. I honestly take having healthcare for granted because I've had it for so long, and being in a culture that is constantly inundating me about the importance of the health of the baby. But not everybody is in that culture and in that environment, and people are living day to day. So I think that we have to really focus on decreasing barriers. I'd really like to see policy focused on, if you're going to create another program, how is it decreasing barriers? Because I've also seen, this is not a popular thing to say out loud, I have seen a lot of grant money wasted because you have these fancy, shiny programs and people aren't engaging in them. So we also did a study where we asked women, why are you still here at Healthy Start? Because it was unusual that we had like an 87% retention rate. It's really unusual to have women come in the beginning and then stay in for a year and a half. And they were like, it's all about the persistence of the case manager. It really blew me away. I thought it was going to be like stuff that we get, or the events that you have. It was like, oh no, it was that this case manager called me over and over until I really started using the program. Like they kind of would sign up to get the free diaper pack and then be MIA. So I think that there needs to be a lot of policy emphasis on decreasing barriers around mistrust in the community and requiring agencies, hospitals to involve community members in some kind of decision making. Like, why not have community members teach us, the social workers or the medical providers, here's what we're facing on a day-to-day basis. Here's what we need. If you really want me to do something different, you got to educate my grandmother because she will not shut up about putting the baby on her stomach. Like, that's the reality. So I think that's what I recommend for policy is that if we can just focus more on prevention, prevention in the community and community listening to the community, because we keep educating kind of over people's heads a lot too. Go ahead.
And our last question for you is, what are the next steps or future directions for your research, particularly concerning maternal behavioral health?
Yeah, I was just saying that I really wish HRSA would provide, because HRSA is interested in maternal health and they're interested in training behavioral health people. I'm like, give me a grant that will allow me to train 30 social workers a year on how to do assessment with maternal health. Because I think if you could get behavioral health people in the settings or in the community, doing these kind of like, no, how are you really doing assessments and being able to take the time and then funneling them more into the healthcare system or getting them on Medicaid or whatever. I think that that would be really good. I think that if we could focus on this integrated health. I mean, I'm just always going to be passionate about it. And with integrated health, the biggest barrier that is faced there is it was applauded and lauded in the Affordable Care Act, right? We say we want integrated health, but insurance, which really drives a lot of health behaviors and health engagement, has not caught up. There's not good reimbursement yet for integrated behavioral health and medical health. So that's another policy thing I'm always hammering on.
I think that's it for all of our questions, but I did want to read a great comment for you. Dr. Davenport said, Dr. Sampson, I love that question. How are you doing? How are you really doing? I think physicians are busy, and sometimes there's hesitation to ask the question because of possibly not knowing what will come up and how you might address it when the floodgates open up, especially if you have other patients waiting. I love having social workers in every hospital where I have worked. So very, very important.
Yeah, and the floodgate thing is real. When I did a paper like with pediatricians and why you do and why you don't screen, they said we're afraid to open a can of worms. And honestly, I don't blame them. I mean, I'm in social work. I know what you're talking about. Once people start talking about their problems and their issues, it can be very overwhelming. And again, that's why I think getting specific training on brief assessment using something like motivational interviewing, I teach my students how to politely redirect the conversation. It's a skill. You don't have to just sit and listen to blah 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 blah. We've got to learn as practitioners how to be like, I hear you, what you just said, and like you summarize it. So what I'm going to do is I'm going to connect you with so and so, or what I'm going to do is I'm going to find out who to connect you with, and our MA is going to call you back with that information. Right? Like, we have to be realistic that they don't have time. It's true. So I think realistic training to help you work within the confines of the real demands that physicians face with, I know you have to sometimes even overbook so that you can hit your numbers as far as how many people to see.
Thank you so much for being here, Dr. Sampson.
Thank you.
Despite the hurricane and power, thank you so much for being a powerhouse yourself and choosing to be
Oh,
here.
thank
We
you.
appreciate you so much.
Thank you. And thank you for doing this. And thanks for y'all's grace and patience today. And please do reach out. I'll put my at uh, there's my email. I'll be on sabbatical in the fall, but I'm always kind of one ear open because I love research and I love trainings. I love providing training. So reach out if you need to.
Thank you so much.
You're welcome.
And with that, I will actually transition us over to our next set of speakers, Dr. Sarah Page Ramsey, Dr. Natalie Chang, and Melissa Acuna. Dr. Sarah Page Ramsey is the Jane and Roland Bloomberg Professor and Residency Program Director for the Department of Obstetrics and Gynecology at the University of Texas Health Science Center in San Antonio. Dr. Page Ramsey maintains a full-scope OBGYN practice in labor and delivery, gynecologic surgery, and outpatient comprehensive pregnancy and gynecology care. She's contributed to numerous abstracts, publications, lectures, workshops, and courses in women's health and medical education. Her clinical areas of interest include gynecologic surgery, contraception, pregnancy loss, and complicated obstetrics. Her academic career has focused on medical education, student advising, and curriculum development and direction. And we also have Dr. Natalie Chang, who's a third-year resident who is originally from Orlando, Florida. She graduated from the University of Miami with a Bachelor of Science in Biology and a Bachelor of Art in Chemistry. Afterwards, she attended medical school at San Juan Bautista School of Medicine and received her MD in 2022 with cum laude. Dr. Chang currently serves as the House Staff Council OBGYN Resident Representative and is on the Quality Improvement Committee for Hospital-Based Obstetric Systems-Based Practices. Dr. Chang is passionate about high-risk pregnancies and hopes to continue her career in maternal fetal medicine. And with that, I will pass it on to you.
Great. Thank you so much, Yumna. We really appreciate being invited and are very much looking forward to giving the talk today. And I just wanted to express just before we get started, just special appreciation to Melissa, who is a patient, a mom, a wife. And I think it's going to be very powerful for her to share her personal story. And I know that's very difficult for people, so very much appreciate her doing that. Dr. Chang, I think is about to dial back in. I will go ahead and share because she's going to be presenting the first part of the talk, but if she's not quite on, I'll go ahead and share and we'll get that started. Basically, just to kind of provide a framework for how we're going to proceed through the next half hour or so, we really want to give an overview of, I know you've heard a lot about maternal mortality, both in Texas and nationally and worldwide. Today, we will reiterate a few of those statistics, but then hone in on maternal morbidity in Texas, particularly as it pertains to obstetric hemorrhage. And that's going to be the area of focus for us today. So Dr. Chang will walk you through some basics on obstetric hemorrhage. Then we'll be delighted to have Melissa share her story with us. And then following that, I'm going to comment on some of the things that we're doing at our center to try and help with regard to maternal morbidity reduction, as well, particularly with obstetric hemorrhage. And then finally, we're hopeful to empower all of you as attendees about maybe some of the things that you can do. A lot of times we don't realize our power and our abilities on just the personal level that we have the potential for every day. So Dr. Chang, are you on? Did you want to share or would you like me to go ahead? All right, I'm going to go ahead and just share and we'll get you started. Give me just one second. All right. Let me just refresh that so I can get it into the slideshow mode for y'all. I know it'll be a little easier to see it that way. All right, are you able to see my slides okay, Yumna? I want to make sure.
Yes, ma'am.
All right, perfect. Okay, so addressing OB complications, postpartum hemorrhage, and I think Dr. Chang is on with us now.
I am. I apologize. I was having some issues turning on my screen, and
No worries, it happens,
are you able
right?
to hear me now?
You can, this is perfect timing. I got it pulled up for you. And if you'd like, did you want to share it yourself or you want me to just go ahead and arrow through?
That's okay. Yes. Thank you so much for pulling it up. Good morning, everyone. So yes, my name is Dr. Natalie Chang. I'm here with Dr. Sarah Paige Ramsey. We're very excited to be here today and have the opportunity to speak on such an important topic. Ali, I'd like to thank you for inviting us. And I'd also like to give a special thanks to one of our guest speakers that you'll meet shortly. Her name is Melissa. She is a patient that has been that has suffered from a postpartum complication, which we're going to talk about today. And so I'm very thankful for her to be here and share her story with us. Dr. Paige Ramsey and myself work at the University of Texas Health Science Center in San Antonio and University Hospital. And so before we begin, I would like to disclose that Dr. Paige Ramsey is a member of the APCO Board of Directors. She is an APCO board examiner, as well as a Texas level of maternal care site surveyor. She is also a paid clinical instructor for Organon contraceptive implants and is a paid author for Cambridge Publishers, as well as a paid speaker for the world-class CME. I myself have no disclosures to reveal at this time, and we believe that there's no perceived conflict of these roles with any portion of this talk. And so before we begin, I would also like to just set the scene and again, highlight the importance of maternal mortality and how important this topic is. So every 8 minutes, there is one woman that dies in the world during childbirth. And so to put that into perspective, over the span of this conference, there has been 22 women worldwide that have passed away due to childbirth complications, which is a significant number and something to highlight before we begin. The United States ranks 46 in the world in terms of maternal health. We have 2 women die every day due to pregnancy-related or childbirth complications. And the World Health Organization defines maternal mortality as the death of women while pregnant or within 42 days of termination of pregnancy, irrespective of the duration and site of pregnancy from any cause related to or aggravated by the pregnancy or its management, but not from incidental or accidental causes. And this is still an issue that we are fighting and dealing with today, but I would like to highlight that we have made significant strides throughout the last century in terms of the reduction of maternal mortality. The CDC published this table that looked at the rates of maternal mortality over the last century, and you can see here that there has been a significant decline throughout the last 100 years. And when we break it down worldwide, looking at the incidence of maternal mortality ratios, we see that countries that are still heavily afflicted by maternal mortality primarily lie in Africa and Southeast Asia, compared to countries of Northern Asia and Central, South, and Northern America, highlighted here in blue. When we look at the maternal mortality ratios of select countries over the past year, we highlight first a few European countries compared to the United States in the 1980s. We see that the United States is somewhere in the middle in terms of maternal mortality rates, but as the years between 1990 and 2000 progress, we see that there's going to be neither decrease or increase for the United States, while other countries are having decrease in maternal mortality. And then lastly, as of 2008, we see that our rates continue to increase while other countries have either plateaued or decreasing rates of maternal mortality. And that is something important to highlight in this talk, is that our rates are going up while other countries' rates are going down. This is another depictive demographic of our increasing rates of maternal mortality, while other developed regions and worldwide are having decreased rates. Our ratios have gone up by 136% as of 2013. So this is more recent data compared to the previous slide that we just saw. We also have done studies to look at which patient populations within the United States are most affected by maternal morbidity and mortality. We see here that African American women are 3 times more likely to be affected by maternal mortality compared to other races throughout the United States. And so when we look at maternal mortality and some of the causes that can contribute to maternal mortality, is a list highlighted here in terms of one, what the different types of causes can be, and then as well as the rates throughout the last 30, 40 years or so. And so we see here that hemorrhage, hypertensive disorders, infection, cardiac complications, cerebrovascular accidents, to be less common, are some of the different types of causes that we can see that can lead to maternal mortality. And this is something, right, that we deal with still today. Women in our society are still being affected by maternal or obstetric complications. I've put a few pictures here of real life women that we know in today's society and celebrities that have openly shared their complications and obstetric complications. Of course, we know that all of these women are alive today, but did have significant obstetric complications, to include hypertensive disorders, hemorrhages, thromboembolic events. And so these are things to highlight. We, on the next slide, have one person to highlight. So she was a gold Olympian, Tori Boeing, that died at the age of 32 from a childbirth complication. To our knowledge, had no significant medical history or anything that could have been perceived, but she did pass away in her home secondary to a childbirth complication, which is absolutely devastating and so recent. And so I'd like to take this time to highlight the maternal morbidity in Texas. And so we've talked about world statistics, the statistics of the United States, but also highlighting what the statistics look like in our state. So over the last 4 years, from 2016 to 2020, we can see here the rates of maternal morbidity in Texas. Specifically, the population that is affected the most is non-Hispanic Black patients. We can see has the highest starting rate throughout all those 4 years of data. But something to highlight is that there has been an increasing trend in the prevalence of morbidity throughout the state. And specifically, when we look at postpartum or hemorrhages in our patient population, we again see that non-Hispanic Blacks are the population that is most affected by this. But also something I'd like to highlight is, again, we're seeing either a plateaued or increased prevalence of the amount of postpartum hemorrhages we're seeing, with minimal to almost no decrease. The one population that we see perhaps a slight decrease in is our Hispanic population, but otherwise it's been pretty steady to, if not increasing. And so to define postpartum hemorrhage, we define postpartum hemorrhage as a cumulative that's greater than or equal to 1,000 milliliters or a liter of blood loss, or blood loss that's by vital signs, abnormalities, or symptoms of hypovolemia within 24 hours postpartum. Postpartum hemorrhage is the leading cause of maternal mortality worldwide at this time. So when we look at postpartum hemorrhage and how we manage it, it's very important to identify the source of bleeding to be able to provide interventions to help control the hemorrhage. And so what we teach our learners in terms of what to look for and how to identify a postpartum hemorrhage, the things we look for are, one, the tone. So after delivery, looking at the tone of the uterus, is it clamping down in a way that we would like it to be able to stop that bleeding? Tissue, so is there any retained products within the uterine cavity that may be preventing the uterus from clamping down and stopping bleeding? Is there any trauma, right? So any vaginal lacerations or cervical lacerations that need to be repaired, that is the source of bleeding. And then lastly, any problem with coagulation factors that need to be replaced. And so we call those the 4 T's, to be able to remember and go through those different sources of potential cause so that we can manage them appropriately. On this slide, so still talking about sources, but also risk factors that us as obstetricians have to be mindful of during the labor process and setting up for the time of delivery, and looking at our patients' risk factors. Sometimes there are patients that have no risk factors and still can have postpartum hemorrhages, but it's always we always have to be mindful of the things that predispose our patients and for a postpartum hemorrhage so that we can take the appropriate action and control it as quickly as possible. And so this slide is a representation of some of the things that we can do to stop postpartum hemorrhage, depending on what the source is. And so going towards the top left of the screen, either performing vaginal repairs if there is any laceration to help stop bleeding, using our interventional radiology resources and our colleagues to help us embolize any arteries if needed, if we're unable to control bleeding. This is a little bit more of a drastic step after we've tried other things, but we can always do an embolization of the artery to decrease blood flow to the uterus if needed. Medications, as you see here, we give intravenous medications or intramuscular medications to help control bleeding and help with uterine tone, depending on what the source is. As well as do what's called bimanual massage. So you see here on the top right portion of the screen, this is a demonstration of what bimanual massage looks like. So we will physically grab the uterus from the outside and vaginally to be able to hold pressure and provide massage to help the uterus clamp down. There are also instruments that we can use to help tamponade any bleeding if it's coming from the uterus. So on the bottom left corner, this is what we call a Bakri balloon. It is a balloon that we use to provide pressure onto the uterine wall to help with hemostasis. And then lastly, drastic measures if we can't control the bleeding with all of these other tools that we have under our belt. The final step would be surgical interventions or removal of the uterus if needed. And so I know that we've talked a lot about statistics and patients worldwide in the United States and even here in Texas, but I'd like to highlight that all patients, especially our patients here in Texas are not statistics. They are real people that have real stories and have family members and make true impacts to our society. And I'd like to take this moment to introduce someone here that's going to speak with us today. Her name is Melissa, which I'm very appreciative of her being here today to speak to us about her experience as now a mom of 3 during her first pregnancy and the complications she underwent at that time.
Melissa, we can't quite hear you. Would you mind unmuting?
Hi, sorry about that. I just wanted to start by thanking Dr. Chang and Dr. Paige Ramsey for reaching out to me and giving me this opportunity to share my story, my experience. My story starts about almost 5 years ago now. It was my first pregnancy, and my husband and I were just so excited and consumed by all things baby related, when it came to picking our baby's name and nursery themes and baby showers and whatnot. So the idea of something bad happening to us was just like not even crossing our minds at this point. We were just very happy to be experiencing this. For the most part, I had a very healthy pregnancy. We didn't have really many complications. Towards the end, I was at risk for cholestasis, which is why my OB-GYN decided to have me induced. So we went to the hospital about 5 a.m. At this point. And my parents came along with me, to be supportive for us. And they were in the waiting room while my husband and I were in the delivery room. I think for the most part, it was a very standard labor. They started the Pitocin, they broke my bag of waters, and the baby didn't come till about 8 o'clock that night. And my husband and I had decided to wait until the delivery to find out if we were having a boy or a girl. And we had a little boy. So he went out and told the news to my parents, and they were just so happy because it was their first grandson. They came into the room and congratulated me and held the baby and decided to go home to get some rest. And they would come back to the hospital in the morning to help out. At this point, maybe like 10 o'clock at night, my labor nurse was giving me the abdominal massages, and I felt fluid coming out. And she told me that it was blood, but that it was normal. Everything would be fine. And they took me down to the recovery room, and I had a different nurse at that point. And I started to feel contractions again, and I complained about the pain, and I told my nurse, I'm starting to get pain. Can I have some pain medication? She came in and checked on me, went out to get the medication, and I just felt like I had wet myself. I felt like so much fluid coming out of me. So I paged for the nurse again, and a different nurse came in, and I told her, I just feel really wet. Like I need to go to the restroom. I need to change myself. And I sat up and I tried to get out of the bed, and I just felt extremely lightheaded. And I sat back down and I said, I can't, I need to lay down. So she helped me lay back down, and she took the blankets off of me. And she just had this look on her face of like, I think she went pale, like she was just in shock. And she asked me, when is the last time your nurse dressed you? And I told her 5 minutes, maybe 10 minutes, not too long ago. And she just called out this code. And before I knew it, there was like 10 people in the room surrounding me and around my bed. And I just kept looking for my husband at that point, who he was backed up into like a corner. And they were telling me all types of things, what was going on. But in that moment, I was just like, what's going on? Because there's so many people in here, and they were telling me that I was hemorrhaging. They were going to give me some medication to try to control the bleeding. And I just looked at my husband and I kept telling him, like, it's okay. This is okay. We're going to be okay. So during the pregnancy, sorry to backtrack, but we actually did take a birthing class because we wanted to be a little bit prepared on, you know, how pregnancy would go, how the deliveries would go. And we talked about, you know, the vaginal deliveries, the possibility of a cesarean delivery, vacuum deliveries, forceps deliveries, all of that. But they never really touched base on hemorrhaging or things going completely south. So I didn't know what was going on. He had no idea what was going on, but we just had that eye contact, and I told him like things will be okay. So at that point, the on-call physician came in and she told me, you know, you're hemorrhaging pretty bad. We're gonna have to take you into the operating room. So as they're wheeling me out, I just told my husband, like, I'm fine, we'll be fine. And once we got into the hallway, the doctor just kind of looked at me and said, if we can't control the bleeding, we are going to have to perform a hysterectomy. And I know it seems crazy at this point, but in that moment, the thought of surviving this and not being able to have more children was scarier than death, actually. So we go into the operating room, and I've never been in an operating room before. It's just this big, bright room with bright lights on me, and I laid there, and the anesthesiologist came in, and she put the face mask on me, and all I could do was pray at that point, not just for myself, but for everybody in that room, for the medical team that was in there. I just prayed that they would make the right decisions for me and for my family, and that I could make it out of this alive and enjoy all things that come with being a mom, a new mom. So I laid there and they put the mask on me, and my chest got really hot, and everything went black. Once I came back and I woke up, the first thing I did was ask for my doctor. And I said, where's my doctor? I need to see my doctor. And they brought her in a few minutes later, and I just was so thankful to her. And I just couldn't thank her enough for saving my life, because looking back, my life was in the hands of strangers. I felt so vulnerable. I was so scared, but all I could do was pray. And I'm just so glad that their training and everything prepared them for that moment, and they were able to save my life. So my husband came by later on to check in on me. And it was like this big elephant in the room. We didn't really talk about it. I think we were both just so scared, but happy at the same time that I had survived it. During my discharge, my doctor did tell me that there's a possibility I could hemorrhage again during my recovery. And I did. So I was home, and it was maybe like my second day at home, and I went to the restroom and I just saw this huge blood clot. And immediately the fear came over me and the trauma came back, and my husband had to take me to the hospital again. My in-laws were in town at that point, so we left the baby with them. We went to the hospital and they checked me and everything was fine, but I could never shake that fear off of thinking like, oh my God, this is going to happen again. So for my second pregnancy, I think I was still too traumatized by the care, or like being even in the same hospital. So I had to find a different provider. And I was very fortunate at this point to have worked with a group of residents in OB-GYN. And once they graduated, I reached out to one of the residents and I told her, you know, would you mind being my OB with my second pregnancy? And she was very happy. And of course I went in, and she took me in and she asked me to share my story with her, my medical history. And after I explained everything, she took the time, which is so important. She took the time to educate me as to why this happened to me. You know, she said it had to have been, you know, the Pitocin, I was induced, just giving me information. And it gave me that closure that I really needed, because throughout this entire time, I was like, why did this happen to me? What could I have done differently? Why? Like, I felt like I did everything right, and nothing prepared me for that. So by her educating me and just taking a few minutes, it really lifted like so much weight off my shoulders. And I had just like, okay, now I can focus on what's really important, which is this pregnancy. She also did have a plan for me in place. And she told me, you know, this is what we will do once the baby is delivered. We'll give you this medication to help control the bleeding. And I was able to have so much confidence and focus once I was in that delivery room with my second baby. So with the second delivery, it was just completely different. It was the perfect delivery. Everything was well. Even the recovery was so different than my first pregnancy. With my first pregnancy, I remember I'd go upstairs to my bedroom and I just got lightheaded. I was so weak. I was in bed, like I couldn't get out of bed just to like feed my baby. With my second delivery, once I was at home recovering, I was fine. I was walking around. I could hold my baby. I could play with the baby. I was more involved with. I feel it's so important to have that bonding with your baby when they're first born. So then she went on to deliver my third baby, my two little girls. And I'm just so grateful for the training, for the medical team, and for my OB for having saved my life, because I would not be able to have experienced the wonderful joys of motherhood. And with that, every tantrum, every dirty diaper, I do not complain at all, because I am just so grateful to be here and to experience all the good things and the bad things that come with being a mom. And I'm very grateful again for being here and being able to share my experience with you all. And so, yeah, on the screen, that's my son. He just finished his T-ball season. He'll be 5 in September. And that's me with my 3 kids. My son will be 5, my daughter will be 4, and my baby, she just turned 7 months. And yeah, thank you all for listening.
Melissa, thank you. I know that no matter how many times you talk through that, it's got to be really, really hard. And I appreciate that. I'm sure you've touched everybody in this audience today. And, you know, when I first talked to Melissa about whether she was willing to share her story with all of us, what I reflected back on was when I was a medical student, and that's been a little while ago. But I remember that there was a physician whose son, or a person whose son had been lost to a brain cancer. And he came to tell his story. And I remember that as a young medical student, that really stuck with me, to the degree where now, 25 plus years later, I can still actually remember exactly what the gentleman looked like, how he told the story. I remember everything about his story. And I think we need to hear stories like that from patients, because I think it raises awareness. If you reflect on what Melissa just shared with us, I think it demonstrates a couple of important principles that we'll talk with as we go through our next slides. One is that most pregnant people never in a million years think they're going to have a complication. We don't talk about it enough. We don't talk about maternal morbidity and the potential risks associated with reproductive care, with pregnancy. That awareness is so key. We need to make sure people are aware, and that people are in a place where they can get the right care when they need it, and that we educate and train the people that will be delivering that care, whether that's the preventive care, the identification of those people that are at risk for hemorrhage or other peripartum complications, and then finally how to manage it when we are faced with those complications, because only through that strategy are we going to be able to actually affect reduction of maternal mortality. So what I want to talk about in the next few minutes is what are the actions that we're taking as healthcare providers, as teams, and really, is it making a difference yet? What are the things that we can all do? So I want to just share a few of the initiatives. One of the things that we've recognized is that sometimes patients are delivering in very remote areas. They may not have access to healthcare. They may not have transportation to get safely to healthcare or to get into a hospital when they need to. For whatever reason, patients sometimes will deliver what we call in the field, meaning outside of our hospital healthcare systems. And we have first responders that may be involved in responding to those deliveries. And we need to make sure that they're adequately trained and they know what to do and how to respond. And what we found with our EMS, EMT first responders is that although all of them receive some type of education in their training, with regard to delivery and immediate resuscitation of a neonate, they actually don't tend to receive a lot of training in what to do to prevent maternal hemorrhage. And so this was actually something that an EMT raised to me back in 2016 when I was delivering a talk at STRAC, or the South Texas Regional meeting. And he came up and told me, gosh, we got like this little blurb in our training, and we'd really love to learn more. And so we started to put on some workshops. And what we realized was that even at the medical student level, we had future healthcare providers that were still in their training themselves that already knew how to identify obstetric hemorrhage and how to apply proper bimanual massage, that could actually go out and effectively teach under our direction, how to do this. So we set up workshops. This has actually been expanded to a couple of other institutions in Texas as well. So this is something we're doing in our community where we actually go out. They think it's great because, they all talk about it's sort of their biggest fear, but also maybe their greatest joy to maybe deliver a baby while on one of their shifts one night. But we want to teach them about not just how to do that, not just that neonatal resuscitation that of course is so important, but how to stop maternal hemorrhage. So we actually teach them using simulator models how to apply effective bimanual massage so that they can actually prevent hemorrhage while en route to the hospital. And so this is something that has certainly increased their provider comfort. We've done some research in that regard. I can't say that we've got community statistics on whether it's reduced obstetric hemorrhage in the field at this point, because I think it's still new and we're not collecting that data in a very effective way just yet as a state. But I do think that it's really helped to impact provider comfort, at least within our region here in San Antonio. Another thing that's pretty critical to our team, this is a multidisciplinary approach that we've implemented, that we started at a university hospital in UT Health Science Center. And I know many other centers have similar programs. We've talked some at Texas AIM and Texas Collaborative for Healthy Mothers and Babies about some of these strategies, as well as at some other venues. But we've created these multidisciplinary simulations that are conducted on a regular basis. We actually do these in situ, meaning in the same setting where an OB hemorrhage would occur in our unit. So we're actually using our delivery rooms or our triage rooms or our emergency rooms or our ICUs to conduct hemorrhage simulations, as well as other obstetric emergencies. We actually do it for a lot of obstetric emergencies, but our teams function in their normal capacity. If they would normally draw up a medication, we have simulated medications that they draw up. As you can see here in this screenshot, our nurse is drawing up a medication to administer to this patient that's experiencing a hemorrhage. You can see that someone's providing initial bimanual massage. We've got vital signs going and displayed. You can see those over in the corner. So we try to really create that realism, and it gives our team the opportunity to practice how we manage these types of emergency situations on a regular basis. So we're actually doing these monthly on our unit and throughout the hospital. And it's been a tremendous effort. It's taken a lot of planning, but I know many other hospitals and many other institutions throughout Texas are doing similar things. And I think this is great progress forward for us to practice our response teams and our response management. It's very much at the systems level. And I think that this is a great way forward, and we need to continue to educate providers and make sure that we've got a system where every place that provides obstetric care has at least some opportunity for practice of obstetric emergencies and how you deliver care in your individual institution or location. I also want to give a shout out to our maternal transport team. I think this is somewhat unique, but we're very fortunate to have this in South Central Texas, that we actually have maternity trained nurses who work with us regularly on labor and delivery, postpartum, antepartum. These highly skilled nurses actually go out and get patients to bring them to a higher level of care when that's needed. I think hopefully most people on this talk are familiar with the Texas levels of maternal care, and that's a designation process, so that depending on the resources that are available at each place that delivers obstetric care that can help us delineate what a patient might need. And sometimes a patient needs different NICU support, different intensive care unit support. They may need blood product support that one hospital may not have the resources for, even though they have very skilled people there to deliver it. Without the resources, they may need to get that patient to a different center. Our Stork One maternal transport team will go out and get those patients and bring them to us if we need. And this is, an effort to help reduce maternal mortality and to address obstetric hemorrhage, obstetric shock, and get those patients to a level of care where they are needed. One of the other kind of unique things here in South Central Texas, we're actually one of the first, we're kind of on the forefront. I know people don't always accuse us of that in Texas, right? But we're on the forefront of whole blood administration for trauma and hemorrhage, along with a couple of other cities in the United States. And actually we were highlighted on, I think it was NBC just about a month ago. So that was really exciting. And that's for the entire trauma program, not just for obstetric trauma, but our obstetric hemorrhage feeds into this. So patients that come to our center or are already at our center that have an obstetric hemorrhage, we are managing them with rapid whole blood resuscitation. Now, some of you may not really understand what that means. The difference between whole blood resuscitation and traditional resuscitation is in traditional resuscitation, you take blood and you divide it up into different components. There are red blood cells, which are the cells that carry the oxygen. There are also other factors that help blood to clot. All of those can be very critical during a hemorrhage situation. Whole blood provides all of those at the same time. And so this is a very unique approach to managing obstetric hemorrhage, but this has been a vital approach for us, both with our placenta accreta spectrum program, which are very high-risk patients for massive hemorrhage, but also our patients that are just encountering normal vaginal delivery that unfortunately has an obstetric hemorrhage to follow, much like Melissa's story. These are the types of patients that may benefit from whole blood administration. So I think this is just another step forward in trying to reduce maternal mortality that's associated with obstetric hemorrhage. I think many centers do something similar. This is just a kind of a picture of what we at our center call our Obstetric Morbidity and Mortality Conference. Now, we're a very high acuity, high risk center, so we do this on a weekly basis, just because of the sheer volume of patients that we take care of in our center. But I think some centers may do this on a monthly basis or a quarterly basis, but some type of review where you're actually reviewing the cases that are impacted in your center. What was the outcome of the patient? What were the factors that maybe put them at increased risk? Are there any systems-based approaches that might enhance the care that we provide for future patients? We are very fortunate at our center to have an outstanding maternal program manager, she's a highly skilled, very trained nurse who actually helps to coordinate a lot of these statistics for our team, and help to push things forward on a systems-based level of how can we deliver the best care possible. And I think that this is a very excellent way forward for all centers that are providing obstetric care. I think the Texas levels of maternal care designation has helped to propel that at many other centers as well. So this should not be something that's unique to an academic institution, but this needs to be happening everywhere that we deliver obstetric care, at least some type of a similar process. And this is vital for us. And then finally, on the state level, as far as one of the initiatives, the Maternal Mortality and Morbidity Review Committee, I know there were some comments earlier, obviously, on this committee, but I do know that they although they review individual cases of mortality, obviously more global, large-scale statistics are reviewed as far as morbidity too, and we need to be addressing, patterns there that we might see. I know that they've created some new dashboards that'll be available so that you can look by region or by county to find out, how your individual area is doing with regard to managing maternal morbidity. So I think just that awareness and that education, we've definitely made some steps forward. what can you do as an individual person? You know, we talk a lot about identifying the issues, but sometimes it's hard to know exactly what to do. And sometimes those little things make a big difference. You know, being aware is huge, right? Many of you are attending here. You may not have a deep medical knowledge just yet. You may not be in practice. There's a lot of different people that are attending here today. All of you are gaining awareness of maternal morbidity and mortality, and particularly obstetric hemorrhage. I think that's really important. We need to make sure our patients are aware of that too. We need to talk about that because our patients, they are our community, and there's a lot of power within that community to impact change. And without that awareness, you know, patients are, without the awareness, no one's going to put the attention on maternal morbidity that it might need. Educate can be just like, can be in this type of fashion. Obviously, we educate medical students, we educate our residents. You know, Natalie is still in her residency, and you can see she's already taken care of and managed thousands of hemorrhages probably at this point. So we know that we do a lot of education that way, but we need to educate our community. I'm always surprised that even when I meet people who are you know, very successful, career-minded, maybe not in the medical field, very educated, they have no idea about postpartum hemorrhage, about obstetric hemorrhage. So just educating your neighbors, your friends, your non-medical, non-healthcare people at the grassroots level is really important as well. And then finally, advocating. Don't forget that you're a voice. Even if you're a young student and you feel like you don't have a lot of ability just yet to make change, you do. You are a voice, and I encourage people to advocate for change, advocate for access to care, advocate for access between pregnancies, and, you know, reach out to your legislative representatives, reach out to your community, reach out to your patients yourself as a medical student. It can make a huge difference. You're already beginning to advocate that way. Just during the time of our brief talk, I just want to reflect back on what Dr. Chang said at the beginning. 4 more obstetric patients have lost their lives just while we talked today. And I think that that's pretty meaningful and impactful. And I hope that that sticks with you to help you to realize what a significant problem this is, that we should be able to do better. This is our contact information. Dr. Chang and I are always happy to answer questions, collaborate on projects, et cetera. We both share a strong passion in this area. We really appreciate everybody taking the time to listen. And again, Melissa, we thank you so much for your story. And I hope that 25 years from now, there's somebody who was impacted and will remember your story the same way that I remember the one that was shared with me when I was a medical student. So thanks for doing that, even though I know it's very hard.
Thank you.
And we actually have a couple of questions in the chat if y'all are open to it.
Yep.
We have one
I'm
from
gonna
Dr.
stop sharing.
Davenport. I may have misunderstood. At one point, I heard they might start publishing individual physician postpartum hemorrhage rate. This was troubling for me as an OB hospitalist working at a tertiary facility where we have high-risk patients, which drives up rates. It sounds like what you mentioned is they will publish by region. Is that correct? And what are they publishing? The rate of postpartum hemorrhage or the rate of appropriately managed postpartum hemorrhage?
Yeah, great question. And I share the same concern as a physician. I think that things are so multifactorial when it comes to managing hemorrhage that often people can make conclusions about an individual provider based on statistics without a lot of explanation, right? So I share the same concern that individual provider statistics can be very daunting that way. I am not aware of an initiative to share individual provider statistics in that regard. I know that there may be some hospitals that individually choose to do that, or some departments that choose to do that, but I'm not aware of anything like that coming from the state. So my understanding is the dashboards are more regionally connected as far as rates of maternal morbidity events. And I'm not sure that there is any review to determine whether or not they were properly managed. I've not heard that initiative. I don't know if anybody else on the call may have more familiarity with that, but I'm not aware of that being an initiative.
And we have another one. What specific training or resources would you recommend for medical students to better understand and address the causes of maternal mortality, particularly as some programs do not address that in their curriculum?
Dr. Chang, please feel free to share any thoughts from your regard too. But as a residency program director, I do think, maternal health care is something that needs to be brought into undergraduate medical education or medical student curriculum, perhaps a little more heavily. I'm sure that every specialist feels that way. Let me say, the cardiologist probably feels like we don't learn enough heart stuff, and the ophthalmologists think we need more eye stuff. It's definitely a gap. Absolutely. And what I encourage students to do at this level is when they're on their OBGYN rotation, I think that's a great opportunity to better understand, even if they're not going to go into OBGYN, every medical school is required to have an OBGYN curriculum, which is great. It's a great opportunity for you to learn a lot more than just pap smears or delivering a baby. Ask questions. How does this impact future hypertension management? What about the patient with underlying cardiac disease? What can I do as a doctor who maybe is going to go into another field like internal medicine or family medicine? What can I do to help that patient have safer pregnancies? Asking those questions to the OBGYNs while you're on your medical student rotation is a fantastic way to increase your medical knowledge. No matter what field you're going to go into, because only about 5% of people go into OBGYN actually. So I know it's shocking, right, Yumna? We can't imagine why it's not 100%, but I think that it's a great way to understand how it might impact you in another specialty area as well.
And I've got one more for y'all, and then I will leave y'all alone. How can healthcare systems better support OBGYNs in their efforts to prevent maternal mortality?
Boy, this might be a whole nother talk, Yumna. Is it possible to get another slot? No, I think a lot of it, I think staffing is a big issue at a lot of places, right? So hiring actions to make sure we have adequately staffed units will make a huge difference. And what I mean by that is nursing support, medical assistant support, both on the inpatient side and on the outpatient side. I think that we still continue to struggle, quite honestly, with reimbursement of fields related to women's healthcare. And I think that that's an area that we need to kind of work on. But as far as hospital systems, I think the staffing, allowing the OBGYNs and the OB nurses to be important parts of the different committees that determine equipment uses, logistics, budgets, staffing assignments, operating room availability, and having access to that. We need to make sure that we're staffed up and supported 24/7 to be able to care for not just obstetric hemorrhage like we focused on, but hypertensive emergencies, eclamptic seizures, thromboembolic phenomenon, et cetera. So I think just having the staffing and support and the finances actually dedicated to it. I think because women's healthcare has not historically been a super well reimbursed field in medicine, sometimes, totally understandable, but at the hospital administration level, you're looking at things from a cost-effective standpoint, and obstetrics may not be, deliveries aren't always bringing in the dollars that some of the other specialties are. And I think that can sometimes sway the attention away from the support, the staffing and the equipment that's needed to properly give care to patients.
And I totally fibbed. We have one more question, but it's a fabulous one. It has become more popular recently to have natural or at-home births that are unmedicated and away from OBGYNs. Does that affect any of the recent data with regards to maternal death and complications? Basically, is the birthing process effective or not in changes, or is it the same for risk?
Well, I think one of the things we have to ask ourselves is why this change, why this trend? Because we, of course, when you ask fairly traditionally trained OBGYN, my perspective, my view is going to be, gosh, I've seen a lot of bad stuff. I want to be able to have my patients deliver in a place where I can give them anything they need at any minute. And that isn't always the case when we're outside of the hospital setting. That being said, we know that hospital settings have their own complications and issues as well. And I think there's a lot of media around that. And I think that it shows us that our patients are maybe sometimes afraid of the hospital setting, or what type of care they're going to get. And so I think that we need to better understand where our patients are coming from on that. I think we need to work within our communities to educate, and to listen to our patients' needs, and to find ways to deliver healthcare in a way that's safe, but also providing the patient the things that they perceive are most important to them around their birthing story. And I think that a lot of centers try to do that, but I don't think we're there yet. And I think for that reason, some patients feel afraid of the healthcare system. Maybe they themselves have had a complication, a medication error. Maybe they had a family member that experienced a complication. It could be any number of reasons. As far as how it impacts the data, all patients, whether even if they deliver outside of or inside of the hospital, any reported births would be included in the statistical analysis and the data reports. So I don't think that makes a direct difference there. And certainly we know that when obstetric hemorrhage, maternal morbidity, maternal mortality absolutely occur out of the hospital setting as well as in the hospital setting. So I think it's something that's very real in both places and important to educate on.
Dr. Paige Ramsey, I think you highlighted on very important things, especially the portion of education. I absolutely agree with that. Educating our patients and also educating ourselves, right? Educating ourselves as to how, when, why the patients are having apprehensions about going to the hospital, listening to our patients and understanding and meeting them where they're at, but also providing them with resources and educating, like we had talked about earlier. A lot of people are not aware of postpartum hemorrhages or potential complications, and having those conversations throughout pregnancy visits can be very important in providing patients with that information so that they can make choices as to how they're going to deliver moving forward.
Thank you guys so much. With that, we'll wrap up our Q&A. Thank you, Dr. Paige Ramsey, Dr. Chang, and Melissa. We are so grateful to have you here. Y'all are powerhouses, and it was amazing to hear from you. So thank you so much. And with that, we will transition over to our next speakers. I'd like to introduce everyone to Morgan Miles and Janixa Ramos Almodovar. Morgan Miles is an Austin-based birth worker, social worker, and executive director of the community doula organization, GALS, Giving Austin Labor Support. She creates a lasting difference in people's lives by bringing over a decade of birth, leadership, and change work experience, coupled with a trauma-informed, anti-racist, and family-centered lens. Morgan believes that in order to eliminate birth and perinatal health disparities, we have to work at every level: direct care, systems work, and legislative action. She also believes that true, lasting change takes place in community where humanness is centered and joy is abundant. Janixa has been serving the birthing women since 2014, starting out as a doula and working her way to become a midwife through the Mercy in Action program. As a Latina and Afro-Caribbean, she finds passion in connecting to the community and is fluent in Spanish. She believes in empowering women to feel in control of their pregnancy, birth, and postpartum with compassion and tenderness. And with that, I'll pass it on to Morgan and Janixa.
Thank you. We're going to share our screen. Here we go. All right, so yeah, I'm Morgan, and this is Janixa. Hello. We've been really enjoying the conversation today. You may have seen me in the chat. I'm very passionate about all of these topics, and think it's definitely important that all of you are here and listening and learning from all these different perspectives. And we're excited to continue the conversation and talk a little bit about some of the other presentations today as well. So what we're going to talk about is we're going to talk about doula care. We're going to talk about midwifery care, how those two areas promote health equity. And then we're going to talk about strategies for integration into the broader healthcare system of doulas and midwives, some of the challenges and barriers that are faced in doing so, and some next steps that y'all can hopefully use moving forward. Okay, so I'm going to get us started with doula care. For those of you that don't know, doulas are an evidence-based way to improve birth satisfaction and reduce health complications for birthing people and infants. Doulas are trained, non-medical members of the care team who provide expert guidance, emotional, physical, and educational support from preconception, pregnancy, childbirth, miscarriage, stillbirth, and 12 months postpartum. Doulas provide families with research and education to support positive birth outcomes. We're trained to know what's normal in pregnancy and postpartum, and that if a birthing person experiences something that's outside of that realm of normal, we refer back to healthcare providers. And we also support the whole family. So looking at dads, partners, grandparents, adoptive parents, any other families and friends in the support system who is going to be supporting the parent and helping them take care of the baby. Additionally, there's a couple of different types of doulas. There's like your conventional or conventional doula, which is like a trained person who also is hired by families and paid for by families. Typically, higher income families might elect this, and that is a specific type of kind of doula. And then there's a community-based doula, somebody who is primarily working with folks who are on Medicaid or under-resourced, someone who has shared lived experience with the families that they're working with. And though that perspective of doula work is really addressing social determinants of health, and all doulas really are improving health literacy or empowerment of the families to be able to know what they want, to ask for what they need, and to how to ask questions and critically think about their care, whether that's an obstetric care or a care across the lifespan, and ultimately advocating for equitable care. And because of this, we've seen routinely that doulas are part of a factor of improving maternity care. We see in the research that doulas advance health literacy, helping families feel empowered in their knowledge and what the physiological process of pregnancy and birth look like. We also help increase the agency and confidence of the families. So making sure that families know how to have those conversations with their healthcare provider, feel confident in asking them questions, slowing down the room when they're like, I don't know what to ask in that 15-minute appointment, and I have this list of questions, and then I walk in the room and my mind goes blank, like what to do to make sure that they have the care that they need. And then ultimately, because of that health literacy and agency and confidence, we see improved birth outcomes. You can see some of the statistics here, but we see lower preterm births, lower cesarean birth rates, less use of epidurals, higher incidence of breastfeeding, and the like. And because of all of that, we also see cost savings. There's been several studies about the cost savings of doulas, but what we see is that the average cost saving is anywhere from $900 to $1,100 per occurrence. And we think that that's underestimated because of the amount of kind of avoidance of the NICU that we see. We know that that can be a huge expense for families and for the healthcare system when NICU stays are happening. But we see that, higher birth weight babies, lower preterm babies with doula care. And with that, I'll pass it to Janixa.
Hello. We work midwife. I'm a midwife, and we work in different settings: home birth, birth center. We also transfer to the hospital, right? We know it's normal. We're trained. We bring medication to out of hospital birth, and we're medical members that are trained to know what's normal and what is not. And by this, we start always the initial visit of knowing the person, knowing the history, always ask if this is the first, the second, what happened in the second. And we take an hour every time with these people, even sometimes more. People need to share, and we need to know them to be able to help them. So it's not just a timing situation. We dedicate an hour for them, and sometimes if they need more time, we can visit that later too. We have to have low risk clients, of course, because we're out of the hospital, but sometimes we have people that have had preeclampsia before or diabetes during pregnancy, and if everything looks normal right now, even with that history, just by changing their diet, people can make a huge impact of not having preeclampsia again, not having diabetes again. And that's how we check those numbers at the beginning. We can manage the diet with them. What else? Like being off hands during labor, it's makes a huge difference too. We make sure baby sounds great. We do vitals, but if there's nothing to do, we just need to wait. That's a big part of avoiding complications, because if everything looks normal and they just need to sleep or eat or rest, like we just let them be. Baby sounds great. There's nothing else to do. We just give them a break. And sometimes, yes, you can be there for a long time, but we respect that, look at that, and we also have many midwives that can come and help if if we need to rest. But there's not a clock here. If everything looks normal, because especially first time mom, they need that time. And we do know, like, we know what is not normal, and we send people in. We do sonogram. I mean, we send people to get sonogram to make sure everything is well, and especially if they're passing that 40-week, 41-week, we send them to check on baby and make sure everything looks great. Yeah.
Yeah, so because of this, midwives are also part of improving the maternity care system. So this is some more data about improving maternity care. Like Janixa said, like extended prenatal care is so important, an important part of midwifery care model. Care is can be done in home. It's also sometimes in a clinic or a birth center, but it's typically much longer appointments, up to an hour, sometimes more. And what that is doing is really helping like families understand and know, like trust their provider, but then also like talk about all of the other things that are happening in pregnancy care, right? Like so often pregnancy and birth and postpartum is like, it's like a microcosm of all of the bigger issues that are happening in a person's life, from the fact of the income that they make to their access to food, to their transportation, to
the more we know, the more we can help. Like these people bring their kids to the room, they bring their mothers, they bring whoever is around them. And everybody can ask questions. It's not just the mother. Like we know what they're eating, we know what stress they have. We know how to give resources to try to give them a better start. If you know what's happening, you can help. And I mean, it's not like we're going to save everybody, right? But just knowing what's happening and help them to, okay, you're eating that. What about these? I know you have to work, you have all these. What about if you can bring a few snacks with you? What about water? Just increasing all these diet and time and resting. A lot of time we do a lot. Just gotta try to go earlier and have a bath every night. And like all that can help keeping you healthy. I think one thing that we need to understand and make sure it's like how to work together, because I mean we're trained, we're doing these together, and we can keep people safe if we respect each other and we know that we're trained, we know what we're doing, and going in I'm having this person and I need to be seen. Like there's been a few times I send people in, go back home. I'm like, oh, I wish, like let's just monitor a little bit more and see what's happening, because you can sometimes, most of the time, you can see it coming, and because we know normal, we know people. So understanding the work we do, that we're trained, that we bring medication, that we know these people, because everybody's different. They may need, they may be great in your numbers, but there's something deeper that can be changed really fast. Yes, and midwifery, I mean, compared to hospital, it's really cheap, and I think these gaps in the hospital can be by staffing. I mean, bring more midwife. We're happy to be there and wait and monitor and see beautiful things happening, And I think a lot of times, because like the hemorrhage, that is something so big that I hear, and I'm so glad and lucky I have never lost anybody to hemorrhage. And we have different medications to stop that. And we're there, like we're there 3 hours at least. It's a minimum after birth. We're there in the room with them. I mean, so I'm not saying they're doing anything wrong, but it's what we see at home. And, we go slow, we didn't take the baby, like baby's stay connected to mama. And we're there watching. And of course we do vitals. Of course we do we have the same thing. I have oxygen, I have 3 types of medication to stop hemorrhaging. We have master baby, we have a bunch of things. So I think, yeah,
Yeah, and what I think too, as a doula, right, like we know that like what 93 to 98% of births happen in the hospital. But midwives practice also in the hospital, whether it's like with transferring with CPMs going to the hospital with their patient or CNMs working in the hospital setting, and being able to be the first point of contact for families, because birth is normal until it's not, right? But if we assume that birth is not normal from the beginning, then we sometimes over monitor, oversee, we get some of these issues of like where parents are like, well, yeah, my provider's not listening to me. It seems like they're not listening to me. They're not paying attention, or they're not doing these things, or they're only like talking to me about all these terrible things that might happen. But I feel good. I'm safe. I feel like all my vitals feel normal. Like this is what the standard says. This is what the evidence says. So it's like the juxtaposition, right, of like what a doula does and what a midwife does are, as like Alice said in the chat, right, like we are the kind of bridging the provider's not listening to me. It's like, okay, well, we are able to be here and to listen and to help you feel more confident in your care, whether that's from an obstetrician, as a doula practice is supporting, or as a midwife is taking care of a family.
Yeah. And right now here in Austin, midwife need more doctors that are able and happy to help and work with us. Like we need that to keep people safe. Mm-hmm. And we only have one person that it's like a few person that are okay with that, but everybody needs a break. So it'll be great if we can work together. Like if we can send a person to someone with the medicine just to have a sonogram, and also a lot of time it's people cannot pay for it. It's just so expensive too. So if we can, like, I don't know, make a gap for these people that have midwifery care, let's just, because they cannot pay for that, right? And I mean, we always ask to do them, and if they cannot afford, we find a way to make sure we can check stuff. Yeah, we need more support and help. Let's see.
Yeah, so we're definitely going to dive more into some of the ways we can better integrate, like work together for each of our professions. I think that first we need to talk about why doulas and midwives do advance health equity and what is our mechanism for that. And so the first piece is the autonomy, right? The family has the right to make their own decisions based on their values, beliefs, and preferences, but we use unbiased information rooted in the latest evidence-based care and respect their choices, even when it goes against that care, right? And so the autonomy piece is crucial to the doula care aspect, speaking as a doula, right? Like that is really what we live and breathe in, is helping them understand what their rights are, what their decisions are, and understanding all of the different options. And midwifery care obviously is very much aligned with that too. We also, practice in the same way of like do no harm. So prioritizing the physical and emotional well-being of parent and baby, minimizing unnecessary interventions, using the BRAIN acronym to slow down decision-making, which BRAIN, for those of you that don't know, what are the benefits? What are the risks? What are the alternatives? What does my intuition tell me? And what happens if I say not now, not yet, or not at all? So anytime that an intervention or a procedure or something, a change in care plan is suggested, we can help families know how to walk through the BRAIN acronym so that they can evaluate if this choice feels like what choices are out there. Is there, because there's always many answers that could be right for a family in various circumstances. And then really just centering that the birthing folks are the ones with the power. So often the families that I work with have that white coat syndrome where they feel like, oh, well, the doctor is the one that knows. And so even though like I am feeling like I have a fast heart rate, I have a headache, I have spotty vision, but they're saying this is normal. So I guess it's normal. And we can be like, you are the one that are saying that you have these symptoms and this might not be normal. And so if you feel like this is unnormal, you are the one with the power. You need to advocate for your care, seek a second opinion, go back and like make sure that you have that you're seen and that you're heard. Like that Hear Her campaign is like the root of doula care. And then finally, like doing good, right? So a care team that's culturally similar that values the unique lives and experiences of the patient. So just because I come from a similar background, I look the same, I speak the same language, doesn't mean I know perfectly what this family is experiencing. So while that similarity is important, it doesn't mean that we know what's best for them. And so they are still the center of the care, and we value their independent, like lived experience and what that means for them. And then continuous support is crucial to doula care, easing pain and discomfort of the family, mostly by reducing fear. And then attuning to the family too. What is it that they're needing? Really picking up on those, like the room, like the energy of the room. Okay, when this person walks in, I notice that your contractions feel like get more intense. So what can we do about that? Is it that we need to send your mother-in-law out of the room and maybe wait in the waiting room for a little bit longer? Is it that we need your partner to kind of take a break and go for a walk so you can recenter and we can have a conversation about what's best for your care? Is it that, you know, that nurse is not the best fit for you and we need to ask for a change? All of these things are possible, right? So, but we can only know it if we're in the room for a long period of time and can attune to the client and what that energy, when that energy shifts. Or maybe like a trauma is being reactivated, and we know that because we know their trauma history. So we're able to be like, hey, every time they come in here and this happens, I see that you're being triggered. Like, would you feel comfortable with me stepping outside with the provider and talking about your history so that they're more aware of what's going on and why you're responding in this way? But ultimately, the goal of doula care and of midwifery care as well is to enhance the birthing person's overall satisfaction and empowerment. So a lot of today has been focused on, right, maternal mortality and morbidity. And my shirt says surviving pregnancy is a human right, right? And I believe that. And putting death as the baseline of what is healthcare is not what we should be doing, because just simply surviving pregnancy is not enough. We need to have thriving families who are satisfied with their care, who are empowered from their care, who feel like they're able to really like blossom and be supported with this new infant or infants after birth, right? So that piece is really important, that this is a baseline, but it's not enough. Just stop there. Yeah. Anything you want to add to that? Sorry, I got off my soapbox a little bit.
That was awesome. Yeah. Let's see.
Well, let's talk about collaboration. And this is where Janice and I are going to kind of have a little bit of a conversation now rather than like just reading off the slides, because I think the experience part is like, that's kind of the meat of this, is like, what have we seen? What have we heard? What's worked? What hasn't, and why? So I'd love to hear, as a midwife or as your experience as a doula, either one, what has like a really good experience of collaboration with the broader healthcare system looked and felt like for you?
Yeah, that's a great one. I think now there's one person in the hospital that knows me, and we have been working for years and respect me. And now I'm going there and it's like, okay, everything looks normal. But I hear this, it's like, okay, so we need to check for that. And when things happen and you know, like as a care provider and midwife and all, you know, it's like, oh, that was right. It's so good because all the numbers were in range, but still, you know, like there's something going on with this person, and then they have a great outcome, and they can be both great and healthy. And that was a great collaboration. You know, that has happened with preeclampsia, with twins, with many things. So it is so great when you have people that trust you and trust that you give a good care, how we can improve maternal outcome, and you know, having a safe family, a happy family, and a person that it was having a great experience. Right now, I'm with midwifery, had a lot of people that comes from the hospital with a lot of trauma, and it's a lot of cleaning, and more than midwifery care is a therapy session too. And it's just, you know, trying to give the power to them, you know, and they're the ones who we need to work together, right? Because it's not only the work that I do, like mothers need to do the great care, staying healthy and choosing good decisions in food and staying active and all that. So yes, it's a
Yeah, I think for me, having been at births where the provider was not doula friendly, versus births where the provider or nurse was, is such a huge difference in the client's experience. Because the one that stands out for me, where I was clearly not accepted in the room, the care of the patient was way worse. And that's so terrible, because that family chose to have me in the room for their reasons, and, you know, trusted me and provided in me. So when the care provider said, I don't trust you, you're not going to get good care because you have a birth plan, that means that the family is now hurting from that, right? And so when things have gone well, it's, hey, like, you've probably seen this happen before. What are some positions that you think we should go into right now? Or I look at the monitor and I see, you know, double peaks. Oh, the baby might be sunny side up, or they might be, you know, I know I have been in this work for so long that I'm seeing things. So being able to be like, hey, I'm noticing this with the provider. Can we maybe like get her walking? Can we get that electronic, like, external monitor that will let her be able to walk around the room and hopefully like help baby kind of get into a more optimal position? Or can we get in the shower? Or can we do, you know, these things? And so feeling like I'm part of the team, part of the ideation around the care for the patient, is when I've seen like the shared power, and like families have good outcomes from it because we're all working together.
Yeah, I shared the good, not the bad. One time I went in with this baby, and sometimes, sadly, I think this is something needs to be said now that I'm talking about it. When the ambulance come and we need to transfer, now the EMS team has to do their steps, but we have done those steps, so we need to go and move really fast. Like, that's something that needs to be addressed and changed, and we're working to have a meeting with the guys and let them know, like, this is how the stuff that we have, this is how we do it, we need to move fast. So I had this baby that needed to go NICU right away, and I just took baby in the car because I'm not going to wait and for EMS to come here and then take a long time to go. So I go to the hospital and they're waiting for EMS. When I come here with this baby, we already talked to the NICU team. They're waiting for us. But the doctor on the emergency room took baby and they worked on baby and did so many things that were not adequate and wrong, that, you know, it was really hard to see and watch, and I was yelled at, and it's just so sad that, you know, sometimes they don't know what we do and that we're trained, and the baby just needed care right away. That baby's safe, that baby's okay, but it's like, why do we have to, you know, pass rule that when it's like, I called, this is what's happening, this is what needs to happen right now. But we didn't got the care that we needed right away. It took like an hour for that baby to, once we got there in the hospital, to transfer that baby to NICU to get the care he needed, and I knew what was happening. But they have their steps that they have to go through. I understand that, but if we have an understanding of the work that I do and the midwife do, it will be much easier. Like, this baby needs to go to NICU right away, and we can have this baby. So that was something.
Yeah, it makes me think of this part about shared power, right? And like the last presenter talked about having like the review, weekly review sessions at their hospital, and thinking about like, that's amazing. We've seen in the history of the US, like, right, the 90s had reviews every week of cesarean rates, and we had a really low cesarean rate at that point in our time. And then we stopped doing things like that. And then all of a sudden, like, cesarean rates are now 30% and like holding steady, right? And so what tables like that do you sit at as a provider? And are doulas and midwives present? And not just CNMs, but CNMs and CPMs and doulas, birth workers in the community. Because the reality is that we're all seeing these same families from different perspectives. And all of those perspectives are super valuable in moving the needle on health outcomes. And so if you have a seat at a table and you notice that it's all nurses or all doctors or all whatever, that could be a problem to seeing some of the gaps in care, right? And so add doulas, add midwives, add birth workers to those tables, and that will also help with the care of the patient, whether it's whether it's because of, you know, fear and the distrust of the healthcare system, like we can help improve that. Doulas especially, or we're like, hey, you trust your provider. Tell me about what's going on that's making you question this. Like, what's going on here? What do you need to feel safe? Because safety is so important in birth, right? Like our oxytocin doesn't happen to have the baby if we feel afraid, we feel scared. Like we have to be safe in our bodies and in our minds to like be able to progress naturally and unmedicated in labor. Unmedicated meaning not Pitocin, right? And not epidural or not, you still have to feel safe. So yeah. So yeah, like we're talking about some of the barriers, right? And some of the situations that have gone wrong. But the biggest thing that we can talk about is like the power dynamics is so important. The power dynamics that are at play, and even within the hospital setting, for like CNMs versus OBs, what does that look like in your hospital? How is power shared or not shared? Is it that, you know, OBs are like, oh yeah, we trust you. We know that you're going to take good care of our patients. If they're low risk, we're referring to you. Or is it, oh, you're going to just like do all the triage. And then we're going to be the ones that are still managing the care in this low risk family. What policies are in place in the hospital setting that hinder the true collaboration of care? And is there ways that you can address that or fight that to make there be better policies for families? Because all of this impacts families, right? And then thinking about your own culture and language, right? Like as a Spanish speaking midwife, you've seen like firsthand how like the language barrier in hospital settings can be so wild in births. Do you have any like thing you want to share around that?
Well, when I started this work, I didn't have any English actually in here, and I was pregnant and getting emotional already. And for me, it was really important to find a midwife that speak the same language because I needed to understand what was happening. And then I started volunteer with girls, and I see very sad stories. And people that are in the hospital, it's like they are not there. There's people start talking and nobody look at the person, and stuff are happening and nobody's looking at the person. And I remember one time I needed to tell a person that, oh, she may have cancer right now, and she just had her baby. And it's like, that is not my job to say, no, go and get a translator, and you tell this mother that just had a baby that she may have cancer, you know? So having a care provider, midwife, doulas, that person there that they speak their own languages so they can feel protected, connected. They feel like they're people and not a number, not a bad, because it's a huge thing.
No, yeah.
It's really important.
Yeah.
People and to see that you care. Like just, it's not a number, it's not a bed, it's not a money, it's a person.
Yeah, and I think as a doula too, I see that too, where like the providers or the nurse and the doctor or whatever will be in the room having a conversation about the family in front of the family, but the family's not included in that, right? And that's like one of the times where it's the doula's job to be like, hey, like pull us in, right? Like the family needs to know what you're weighing. Why are you talking about these things? What are the things that you're seeing? Or step out of the room.
Yeah, step out of the room, have a conversation, and then come back with a person that kind of explain to them what's happening.
Yeah. And you know, all of this, as was mentioned in some of the previous things, time and money are important. So like we know that care all across the board is not paid adequately. Doulas are not reimbursed by Medicaid at the moment, right? Midwives are barely, if they're reimbursed, they're barely reimbursed by Medicaid or health insurance.
Volunteers, really. We give care because we care about people, but a lot of time I didn't get paid for what I do, and I'm okay with that because somebody has to do it. Somebody has to help this family, and I'm fine with that.
Yeah, I mean, and so I think too, like, what power do you have? Where can we advocate on a systems level to advance that? And then I just also want to add that by examining your biases also means examining your data. And what I mean by that is more than just like maternal mortality and morbidity rates, but also like look at your induction rates. look at your augmentation rates, look at your, all of the different things, the procedures that are done, and then disaggregate by race, disaggregate by language. What do you notice in your practice that maybe you don't even realize is happening? But what do you see in those trends? Because that's what we do at GALS, is we disaggregate and we try to understand more of the system that we're working in. But so often we see that even just induction rates are even induction rates for 39 weeks, not even for like a healthcare reason, is higher in Black and Brown populations. Why? Why is that? And so we can't know what we're doing unless we're actually looking at it. Also, I don't know what our time check is, but can you give us a time check on how we're doing?
You're doing great. You're doing great. Hope about 5 more minutes for lecture base, and then if you would like, we can transition into a Q&A because I already see some good questions in the chat.
Okay, great. Cool. So this is also like our last slide, I believe. But this is all about like the integration. So what does it actually look like, right, when we integrate doulas and midwives more into your practice? And these are some of the considerations that we thought of, but I think that there's many, right? So like the biggest thing that we talk about as doulas with each other is like knowing where your scope of practice is. And so this I pulled actually from another PowerPoint I did for doulas, where I was like, know where your scope of practice ends, know when you need to refer. And then I was talking to Janixa about this before, and we were like, yeah, midwives and doulas, like our role is the reason why we operate and how we operate is by knowing when to refer. But also we need to name that like doctors don't have to do that. They don't have to refer. They have like the ultimate final say in terms of like, because they have the biggest scope of practice. So there isn't a like mandated reason to have to be like, oh, well, you're low risk, so I can refer. But are you truly skilled in like hands-off care? And even if so, is there somebody else that you could refer to that can do that, that maybe matches the cultural relevance or the cultural background or the family might feel safer with? Because that's going to be important in changing maternity care and addressing the deserts, the maternity care deserts that we have. Is okay, well, can we add more midwives? Can we add other allied health professionals, nurse practitioners? Can we add these folks who can do this care, who know when to refer when there's something out of normal?
And even just send them to a doctor that looks like them, that speak like them, that they know that they can send these people. That will be, it's very simple to find. Maybe you have a friend, doctor that can do the same job and they look like them and they can speak the same language, and that will be a huge difference.
Yeah. Another thing I want to call out from this slide is that doula's roles are to facilitate communication between families and the care team. That's one of the main things that we do, right? Slowing down decision making and helping make sure there's communication between the two. But what ways can we lean into that team model? And so we see sometimes where like doulas are one of the reasons why doulas are impactful is because we're hired by the families. We're not part of the medical system. Being external to the medical system helps us build trust with the families and then helps us bridge care back to the system, right? So we know how to do that. We know how to be like, this isn't normal, go to your doctor now. Or that seems normal, just call your doctor now. Or that is normal. Yes, you just have a lot of discharge because you're in your late in pregnancy, right? Like knowing that information is really important. But we still see some hospitals, even in Austin, who are saying like, oh, your doula can't come in because they don't have XYZ letters behind their name. But that's not truly patient-centered, trust-based care. And that's not really honoring doulas as part of the health team either.
Yeah, asking for a license when you have a person that has a birth companion, it doesn't make any sense. Like if that person needs and want that person in her birth, that should be allowed. Like why not? I do not understand that. Especially if you can have two people, like you can have your partner, you can have the doula or / whatever.
And then ultimately just improving health equity requires that care is individualized and that we stay curious about ourselves, about our families, about other providers that might be supportive. But the curiosity is key. And for all of us, I'm speaking to myself included, right? All of us have to continuously assess, understand our biases, what we're bringing into the room, and what kind of care are we actually providing for families. Okay, we can take questions.
There's actually one in the chat that popped up earlier. It says, have Dobbs policies impacted your practices? Many of my young friends are having second thoughts about starting their families now.
If the anti-abortion policies. For me, what we see is more adoptions. Recently, we've seen more supportive, at GALS, we've seen more families that are being supported who are choosing adoption. We're also still getting calls pretty regularly, like of people still not understanding that, like, what their options are in terms of pregnancy, unwanted pregnancy care. And so getting lots of referrals. And then I think that, I've worked personally with families who have to travel out of state to terminate like a pregnancy for health reasons or not. And then having to help them process that as they're now participating, like going through the process of a wanted pregnancy and all of the things that are happening with that. So just, I think personally, yes, we're seeing changes, but it's also still just part of the reproductive care that we've kind of always done. It's just knowing that, like, having to be more cognizant of the resources that are available for families.
We're very small, so not much, just sometimes that people were not ready, and now we have to help them to be ready. And
We've got another one. It's, how do you tailor your care to meet the diverse cultural and individual needs of the people you support?
How do we tailor our care to meet the needs of cultural people? Well, for GALS and for myself, it's knowing who to refer to. So who we ask families what's most important to them culturally, what's most important to them in terms of lived and learned experience, and then having birth workers who match at least one of those areas. So Black families often want Black doulas, right? So even if a family in like a private setting, like a private conventional doula comes to me, I might ask them like, hey, is there anything that's important to you culturally? Do you want referrals to some other amazing Black doulas that I know of and can vouch for? Is that important to you? Same with Latina families and any other kind of background is like, what is something important to you and your culture and background for me to know? And is there anybody else that I can pull into your care too to help, like, provide wraparound services if you still want to choose me as your doula or still want to have me as your doula. I can, pull in other cultural workers who can provide other expertise.
Yeah, and the same with us in communication, knowing very well what they need and how they want to manage care, because a lot of times there's many things that I don't know that culturally people do in birth, and I'm like, okay, we'll do it. We'll make the space and we'll do that. And the same during pregnancy, and it's just respect what their feelings and what they want to do in the culture. And of course, if it's safe, it's not safe. It's like, okay, well, tell me more about that, and I will go and search about it. But it's knowing your people and give them space and time and resources to whatever they're needing.
And they're not really questions, but two really nice comments. Dr. Paige Ramsey mentioned that she finds it very helpful that our nurses, CNMs, and others are included in weekly meetings. So she totally agrees with you about that. And Dr. Davenport said, I feel fortunate to have worked as an OB hospitalist at a facility where we truly cultivated our relationship with community midwives in Austin. We also have CNMs on our team, so when home birth patients require hospital transfer, it has seemingly been a positive experience for patients and the healthcare team. The collaboration has been key, and I've learned a lot from the midwives over the years. I also appreciate GAL's support for patients over the years. And then we have one more question for you guys. As a med student, I did notice on my OBGYN rotation that there was a bit of tension between doulas, midwives, and OBGYNs. If a patient opts for having both OBGYNs and a doula, and while birthing in the hospital, what is your opinion on the involvement of the OBGYN during that process?
Involvement of the OB-GYN in having a doula?
In the birthing process when a doula is present in the hospital.
Well, I mean, doulas aren't healthcare professionals, so our roles are pretty like
Emotional support and physical support.
Yeah. So I think for OBs, also like it depends on the practice, but often they come in maybe a couple of times during labor, depending on how long it is, to check in or say like, hi, I'm here, you're doing great, looked at everything's going well. And then they're not really there again until the baby's pushing has been proven adequate and the baby is coming, right? And so in the meantime, the doula is still there consistently and has been, observing the birth. So I think sometimes with what I've loved, and I think I've worked with you, Dr. Davenport, too, but what I've loved about providers who really honor the role of doulas is that they come in and like notice that like whatever dynamic has been working in the room is probably still working, or whatever's happening in the room, I notice that the mom needs XYZ. And so then they are able to be like, I'm bringing energy, or everything is quiet and I'm going to maintain that same level of quiet and care because this is working, right? So like reading the room of what the foundation that we've built together is, and then just like coming in and supporting that.
Thank you both so much for being a part of this. Thank you for all of your insights and your perspectives. We are so grateful to have you. And with that, I will actually transition over to introducing our final speaker, Dr. Ariana Lewis. Dr. Lewis graduated magna cum laude from Texas A&M University in 2013 with a Bachelor's of Science in Biology. She then earned her MD in 2017 from the University of Texas Health Science Center at San Antonio. She stayed at UC Health San Antonio and completed her residency in obstetrics and gynecology in 2021. During residency, she received the Creighton L. Edwards MD Award in Compassionate Care in 2019 and the Gold Foundation Humanism and Excellence in Teaching Award from 2018 to 2020. Dr. Lewis joined the faculty at UC Health San Antonio in August of 2021. Her interests include prevention of surgical site infection, management of menopausal symptoms, medical student education, and diversity, equity, and inclusion in medicine. And with that, I'll pass it on to Dr. Lewis.
All right, thank you so much for that nice introduction. If you give me 1 second, I'll share my screen and we'll get started. All right, are you all able to see my screen?
I see a screen. At the moment, it's a blank screen.
Okay.
And I think it's loaded.
That should be
there we go. Yeah.
All right, excellent. All right, thank you very much. So Yamuna asked me to speak about disparities in Black maternal health care, which is kind of a bit of a broad topic, but I think an extremely important topic that we're addressing more and more often, but just kind of get into some details and some statistics of what we see. I do not have any financial disclosures. So just to start with some statistics, our U.S. maternal mortality rate, I'm sure as we've already discussed this morning, is 32.9 per 100,000 live births. So that's what we were seeing 3 years ago. An astounding difference that you see is in the Black maternal mortality rate, 69.9 per 100,000 versus 29.9 in non-Hispanic white women. So, although we're only 11% of the population, our maternal mortality rate is 2.6 times higher than that of non-Hispanic white women. Even, I think, more impressive is that this rate has almost doubled since 2018, when the maternal mortality rate for Black was 7.3. So almost 60 per 100,000. We say, oh, it's probably parents, and there may this difference persists across all levels of education. So a Black woman who has a college degree is still has a 2 times higher mortality rate than a white woman who has less than a high school diploma. So I think that statement is significant. It kind of makes the point null and void of, well, what about socioeconomic status and education and things of that nature. A 2016 analysis showed that all-cause mortality ratio was 3 times higher for Black women than white women. So regardless, this is a constant issue that absolutely needs to be addressed. In that analysis, the most common cause of death in Black women was eclampsia, preeclampsia, postpartum cardiomyopathy, and postpartum hemorrhage, which is our standard across the board for our mortality rate etiologies. So, we say, well, why is this? Why does this happen? Why do we see this, crazy difference between the Black maternal mortality rate and that of non-Hispanic white women? And I think it's a systemic issue. It's implicit bias. It's socialized racism. So first thing I think is just fallacies about Black women, right? There's the belief that Black women feel less pain if they're asking for pain medicine, that we're seeking opioid medications. We're overly loud and demanding. So why should we be listened to? And then when we do speak up, we're not believed. Our voices are not heard. And then overall, there's discomfort with self-advocacy. We don't want to be seen as the loud, angry Black woman. We know about the mistrust in the medical system to Black patients. We know about the maternal morbidity and mortality rates. So there's discomfort there, but then, regardless of who we are. So I have a couple of cases that I want to share with you all that kind of emphasize the significance of this Black maternal mortality rate, regardless of who you are. So first is TB. Last year, 32-year-old G1P0, she was at 32 weeks gestation, had been missing for 10 days, and her family was worried about her, hadn't heard from her, couldn't get in contact with her. So reached out to try to find her. And ultimately, the cops showed up at her home for a welfare check, and found her deceased in her own bed. The autopsy report showed that she was in labor. There was respiratory distress and eclampsia. Is ultimately what she passed from. I think we can look at this and say, well, yes, that's horrific. But why are we talking about this in the mortality rate? Like, no healthcare teams were involved. But I think there's a lot that's unknown here. Was she properly educated about maternal warning signs and when to seek care? Was she fearful of the medical system? So this is Tori Bowie. She is an Olympic gold medalist. She competed in Rio in 2016. She, along with Allison Felix, who you're probably aware of, who's on her team on the 100-meter relay. They won gold medals there. Allison Felix is also part of the Hear Her campaign for her experiences through her pregnancies and complications. She won the silver medal in the 100-meter run, and then bronze in the 200-meter. So she was accomplished, in excellent shape, well-to-do athlete who unfortunately still succumbed to our Black maternal mortality rate. Next, we have VG. She was a G1P0 at 25 weeks gestation. She was traveling to conference for work. She was with several of her colleagues at this conference when she just started to have severe abdominal pain. She felt like she was cramping, maybe having contractions, and she was worried about the risk of preterm labor. She spoke to her colleagues at the conference, and multiple people encouraged her to present to the emergency room for evaluation, just to make sure that nothing worrisome was going on. When she got to the ER, she had the baby was placed on the monitor. They said baby's heart rate was reactive, reassuring. However, there was not a pelvic exam. There was no tachometer wasn't placed. There was no monitoring for a contraction. So she tried to encourage the healthcare team to evaluate with a pelvic exam. She wanted a cervical check. She didn't want to be aggressive, but she was trying to convey her degree of concern, and that she knew that preterm labor was a real possibility. Ultimately, the physicians diagnosed her with colonic inertia, or just simply put, constipation, without a detailed examination, evaluation for contractions. She was frustrated. She was in severe pain, but she also had a significant fear of being seen as the angry Black woman who was just there to be angry, to throw a fit. Um, and she didn't want to have that picture of herself. So ultimately, she left that town, left the conference, flew home, and went straight to see her, or to see an MFM, and was found to have a short cervix. So average length of a cervix is about 4 centimeters. Her cervix was less than 1 centimeter in length, right? Which I think any of us would tell you she should have been, further evaluated at that location, whether it was for preterm labor or short cervix or management of a short cervix. So a significant shortcoming in a patient who was viable and seeking help outside of their normal healthcare system. This was Dr. Veronica Gillespie. So not just any physician, this is a board certified OBGYN. She, in recounting her story, recalls that she would never send a patient home without actually doing a detailed evaluation, a cervical check, checking for contractions. She's, clearly she was distraught and frustrated with herself for not speaking up and not actively and aggressively demanding an exam, but she was also fearful of what that would look like, and has regrets to this day about how that came across. Ultimately, she was started on vaginal progesterone and delivered preterm at 36 weeks. I think we can still see the discrepancy in care and how that's inappropriate in her case. Next, we have SW. So in 2017, this G1 P0, who had a history of pulmonary embolism 7 years prior, underwent an uncomplicated C-section. During her postpartum stay, she lost feeling in her legs and just had severe pain in her legs. She begged staff to test her for VTE because of her history of PE. She knew that she was at risk, but she was just continuously dismissed. Every time she asked the nurse to reach out to her physician, she was told, no, it's fine, calm down, continuously dismissed despite her fear. She started having shortness of breath, severe cough, and ultimately her stitches on her abdomen opened up and she was taken back to the operating room for repair of those stitches and evacuation of a blood clot. After that take back, she went back to her postpartum room and she kept telling her nurse, I'm dying. Oh my goodness, I'm dying. I feel like something needs to be done. She was told that all the meds were making her crazy. Finally, hours later, her nurse, who was a little bit of a blockade, called her physician, who ordered a stat CT scan, which confirmed what she feared, which was another pulmonary embolism. She was taken back to the OR that day, and a filter was placed. But what stood out to her was that she never felt dismissed by her physician. It was the nursing staff who kept putting her off, even though she was genuinely scared. She's been through this before and she knew what she was experiencing. She was dismissed. Later on, she went on to say, I know those stats will be different if the medical establishment actually listened to every Black woman's experience. That was Serena Williams. I think we would all say she's arguably one of the greatest athletes of all time. She is a presence. You can't go anywhere with seeing her face or without knowing who she is, right? She's the winningest tennis athlete of all time. So Serena Williams is in a hospital with a history of PE, begging for care and being dismissed. That always makes me think, well, what does that say about about the rest of us? Would anybody listen to my complaints? As an OBGYN, is anybody going to listen to my Black patients if even Serena Williams isn't being heard when she voices her complaints or her fears and has this significant history, which makes her extremely high risk? SI. So in 2017, this 36-year-old P0, who also had a history of DVT, Had a C-section, was complicated by a subcutaneous hematoma. She was taken back to the OR. That hematoma was evacuated. And then she ended up having a home health nurse because of picture of pain and elevated blood pressure, who was coming out a couple days per week. Her blood pressure was 158 over 112, and then 174 over 118 at home on recheck. I think most of us would say, okay, let's send her into the hospital right now. I'm, diagnosing her with severe preeclampsia or doing a detailed evaluation. Instead, she was just scheduled for an appointment the next day. Her blood pressure was 130 over 85, and they attributed all of her elevated pressures before to just pain, post-op pain. At her 3-week post-op appointment, she had gained 9 pounds, and one leg was significantly larger than the other, and her BP was elevated still. She and her mom continued to voice her concerns. They said, she just has impending doom, but her labs and Dopplers were negative, and she was ultimately discharged home. Dopplers evaluating for DVT, giving her history. Continued to say that she felt horrible and that she wasn't herself. Later that night, she and her mom went home. They read her daughter a bedtime story, put their daughter down, and she went to her. And 10 minutes later, her mom heard her collapse, ran into the room, and unfortunately found her deceased. So that is Dr. Irving, PhD, who was a CDC epidemiologist. Her work specifically focused on this topic, so structural inequality. She was a lieutenant commander. She had 2 master's degrees, dual subject PhD. She had a home health nurse coming out to her. She continued to voice her concerns and unfortunately passed in this horrible, horrible circumstance. Last patient is KJ. This is a story many of you have probably heard. In 2016, this 39-year-old G2P1 underwent a scheduled C-section that took 17 minutes. Within the first hour post-op, her husband noticed that there was blood in her Foley catheter and that she had vital signs changes. She was a little bit tachycardic. So then they requested that the physician order some blood work, and the blood work came back abnormal. At 4 p.m. that day, they requested a CT scan. She was having severe pain. She was lightheaded, dizzy, fatigued, and she was losing all of her color. Every single hour, her husband, Charles Johnson, was demanding a CT scan. Please, something's not right. Please, something's not right. Please get us a CT scan. At 2100, the nurse came in. She was annoyed that they were still asking for this and said, look, your wife just isn't a priority right now. So extremely dismissive. Your wife just isn't a priority right now. Ultimately, the physician came back to the hospital at 8 p.m. and then again at 11 p.m. He was not concerned. He said, this isn't a big deal. There's really nothing to do. A little after midnight, the residents in the hospital convinced the OB to take her back to the OR. They were extremely concerned for intra-abdominal bleeding. On their way back to the OR, Charles Johnson recalls his wife saying, baby, I'm so scared. The physician jumped in and said, hey, it's not a big deal. Sometimes these things happen. She'll be back in 15 minutes. They were in the OR for over 2 hours. They found 3.5 liters of blood in her abdomen, and she coded on the OR table. So this is Kira Johnson, educated, athletic, well-to-do, loved her family woman. She was fluent in 5 languages. She was a pilot. She raced cars. She was a marathon runner, and she was just looking forward to bringing her second child into this world. You can see on this last picture there was 12 hours past, shortly after delivering her baby. So Charles Johnson, along with Serena Williams, they give testimonies to Congress, really pushing for, advocating for our Black moms and shining light to Black maternal mortality and things like this that should absolutely never happen. Unfortunately, it's a common finding, right? So we just discussed 5 cases of this in these high profiles who are, what to do. And then you think, well, what about our normal everyday patients who don't have this kind of access, who maybe don't have this kind of money, but still undergo these horrible events, and we don't know about it. We don't talk about it. But clearly, the rate 70 and 100,000 is absolutely unacceptable. So then I think, well, like where does right, what is this system racism? What is this implicit bias? And its degrees, right? So first we talk about Sims, who is known as this man performed numerous goal of trying to figure out a way to repair best. So was just cutting on these women, suturing through them, pulling, just absolutely horrific without anesthesia. And this is the man who we say is the father of American gynecology. We all know about Tuskegee, right? So 40 years from 1932 to 1972 was a study on Black men with untreated syphilis. So 600 men were enrolled, over 300 of them who had a diagnosis of syphilis. There was no informed consent. There was no explanation of what was happening, of what the blood draws were for. And in the 1940s, penicillin became available for treatment of syphilis. That treatment was withheld from these men, right? So they went on for 30 years without receiving any treatment, right? So if you remember 3 years ago, when the COVID vaccine became available, there was significant distrust in the Black community because of things like SIMS and the Tuskegee study. Like, why would I trust the healthcare system when it doesn't care about me? Same concept for the maternal morbidity and mortality rate. Why would our patients trust the system, a system that seemingly doesn't care about them? So then you say, well, what resources are available? What can we do to overcome this implicit bias, these things that we're seeing? So I think there's been a significant move towards making things better for our patient populations and making their experience a safer one, but there's a lot to do. So there's class, maternal health care, which is rooting towards bringing up our own biases, making us aware of stereotypes that we see, and making us aware of others' cultural identity and how we can work with them and communicate with them, cultural Black background than us. How can we spoke a little bit earlier about the CDC's Hear Her campaign? Of course, that's Allison Felix, one of our Olympians, who also had a complicated emergency section at 32 weeks in preeclampsia. So I think a significant thing of importance is talking about it. Right? We have to listen to patients and hearing their stories, knowing what could be possible, knowing what to expect, educating our Black patients, so they feel comfortable with the healthcare system and they feel comfortable asking questions and seeking help. So implicit bias, right? So I think that training across the board is required. So we're not just talking about physicians, right? We're talking about nurses. We're talking about scrub techs. We're talking about certified nurse midwives, doulas. We all across the board have to look within ourselves and, why is this occurring, right? Why is this occurring? We already said it's not associated with, that's going on. So you'll hear, I think, more and more in the healthcare system about microaggressions and training for that implicit bias, how we figure out what our implicit biases are, and target that and work on becoming better people ourselves. Every year we have Black Maternal Health Week from April 11th to April 17th, shining light on these topics. To try to reverse what we've already seen. And then we have AIM, so Alliance for Innovation on Maternal Health, right? So setting standards. This is how you respond to maternal early warning time. This is how you manage a postpartum hemorrhage. These are the steps for treatment for severe hypertension and preeclampsia in pregnancy. So if we standardize things and have a guide that we should all follow, nobody should fall through the cracks. Nobody should die of a hemorrhage 12 hours postpartum, despite screaming and begging for evaluation that should be given to them without question. So I, from the patient perspective, right? If you look at the news, it's scary to be Black in America. Imagine how frightening it is to be Black and pregnant in America. You're in the highest risk population. That is absolutely frightening. When I was a chief resident 3 years ago on my REI rotation, REI is reproductive endocrinology and infertility. We had this adorable Black couple, come in for their initial evaluation, and I just remember like, oh man, these patients are great. I hope this works. And out of nowhere, the mom starts crying. She's just in tears. The faculty says, well, what's wrong? Tell me what you're thinking. She says, all I want in this world is to be a mom. I want so badly to get pregnant, but I am deathly afraid of being pregnant because I know I'm going to die in pregnancy. Take that in. All I want to do is be pregnant, but I know my chances of dying are so high that I'm deathly afraid of being pregnant. That's horrific. That is absolutely horrific. Her non-Black friends do not feel that way. She is frightened, and that's the only thing she wants. Which then takes us to, what about our Black physicians and Black nurses and healthcare providers? We as Black physicians only make up 5.7% of the U.S. physician population. And Black Americans, what are we, 11, 12% of the population? Right. And so we feel more comfortable with people who look like us, who have the same experience as us, we can trust, who know the Black maternal mortality rate, right? And I think that goes without saying. So one of my clinics currently is the Robert Hilliard Clinic. Dr. Robert Hilliard was one of the first Black OBGYNs in San Antonio, and was one of the first performing major surgeries in San Antonio. So that much said, it's extremely humbling to work in a clinic named after him on the east side of town, where the vast majority of the Black population in San Antonio resides. I cannot tell you how often Black patient comes in for their initial B visit, and they kind of do a double take, and they're like, "Wait, you're Dr. Lewis? Oh my God!" It's how difficult it is to find a Black physician. I'm so glad. You know how scared I am to be pregnant. Like I just don't want to die. Are you going to be there for my delivery? Can you please make sure I'm alive? My baby's alive. Like this is a regular conversation. Like how horrific is it that this is a conversation that I have every single Thursday? Lastly, San Antonio Metropolitan Health District regularly puts on events during Black Maternal Health Week. So we do panels, speaking to the community, just basic education, right? This is what preeclampsia is. This is what this looks like. Question and answer forums, so patients can ask basic questions that maybe they don't feel comfortable asking their physician. They have doulas, they have lactation specialists, they have certified nurse midwives come out to answer these questions, help patients feel more comfortable, encourage them to advocate, right? Advocate for ourselves. So there is a lot going on to try to improve this, but we still have a long way to go. ACOG, our governing body, American College of Obstetricians and Gynecologists, is very aware of this issue that we face. So I just did a brief search through practice bulletins, committee opinions, so the publications for standard of care. I just searched racism, and this is kind of multiple statements that came up about implicit bias and racism. So physician implicit and explicit bias and overt racism can often result in misdiagnoses and inappropriate treatment. We have to acknowledge that race, institutionalized racism, and other forms of discrimination serve as social determinants of health. One of the things that we do to prevent preeclampsia is treatment with the baby aspirin. And there's criteria who needs to be treated with a baby aspirin. So pregnant individuals with one or several moderate risk factors necessitate treatment. Black race is one of those risk factors, right? not because being Black innately increases your risk, but it's because of underlying racism, right? So anything that we can do to ultimately decrease that risk. So Black race is used as a risk factor. And then, disparities exist due to a myriad of experiences, including systemic racism in the medical system, resulting in mistrust of the healthcare system. But I think what really stands out to me here is that ACOG is just making a point. Like, yes, we know that implicit bias, systemic racism exists. We have to address these, our prejudices and biases to be able to see a change. So I think it's awesome that we're just calling it what it is and being direct about it, and using that to try to make a change for us. So, future, as far as future directions and where we go from here, I think it's important to look at the, multiple factors from structural racism and implicit bias. And I think we have to encourage our patients to speak up, to advocate for themselves, to speak with their families about advocating for themselves, and use resources, right? For example, National Black Doulas Association, doulas, which you just heard in the talk before me, are a phenomenal resource in helping to advocate for our patients, helping them to feel safe, antepartum, intrapartum, and postpartum. We have to educate our patients about maternal warning signs, right? Severe headache, extreme swelling, blurry vision. We should be providing our patients with resources, and we should also be going out of our way to educate them, make sure they feel safe. We have to listen, not just physicians, but not just nurses, everyone who works in the healthcare system. We have to listen to our patients to be able to make a difference, and we have to respond to their concerns. And then lastly, what is being done with AIM, right? So standardizing care, our response to emergencies, in our work to make a difference here. All right, thank you all so much. I'll open up the floor for questions.
We actually have a couple of questions in the chat. The first one was, how can medical schools and residency programs better prepare future OBGYNs to provide equitable care to Black women?
Yeah, so I think the first thing that comes to mind is starting off with education, that there is a discrepancy in the care that's received, unfortunately. Right, so yes, the students need to know that unfortunately this exists, but you as the new generation, you being aware can be a part of driving the change to see a difference. So it would be phenomenal if part of every undergraduate medical education curriculum could, address implicit bias, address systemic racism, encourage, advocacy programs, so that students that are early training are encouraged to say, oh, okay, this is what we need to do. This is how we make a difference. And then when they are working independently, on their own, that they're well aware of this, right? They're speaking up for their patients. They're countering, colleagues, co-workers who are saying, things behind closed doors. I think that's where it starts, just basic education.
Another question we had was, what gaps exist in current research on Black maternal mortality and how can they be addressed?
I think, the biggest gap is, still the why. Specifically, I think in the last several years, we've said, okay, we have this implicit bias, but I think if you go around and ask all of the OBGYNs why we're seeing this with our Black patient population, that most will say, I don't know, I treat all my patients treat all my patients regardless. It would be phenomenal. It could be some of a detailed analysis of pulling up, for a year of detailed looking through their story, Kira, and then holding those. The physician in Kira Johnson's case was had his license suspended for 2 years and then went right back to practicing. And then if you look him up, there's several cases of this just recurrent. So I think that has to be addressed. People have to be held accountable, and we have to be aware of our own stereotypes and biases.
And I feel like that segues really well into the next question. I recall you mentioning in a piece you wrote that not all physicians are bad. For the most part, everyone has good intentions, but naturally it can be ingrained in people and it's a societal problem. What can providers do to identify and address those implicit biases and fundamental issues in their healthcare system that can impact Black women and mothers?
Yeah, no, good question. I think that training. I think training is the best thing that we can do, right? If you ask any of these physicians, like we said, said, no, I treat all my patients the same. Same thing for nursing staff. Like, no, I would never, deny a Black patient medication. I treat all my patients the same. But is that true? So we have to have some degree of insight to how we feel, our subconscious thoughts, and I think implicit bias training against microaggressions is absolutely necessary, and not just saying like, okay, we'll do this once a year on July 1st, and then we'll look back at it, next year on July 1st. I think it has to be continuous, and I think it has to be across the board of all levels of in our healthcare system.
And we have a lot of comments commending you on your presentation. There was one in particular that I just wanted to say out loud. It's from Sarah Shaw. She said, "We are so proud of you, Dr. Lewis. Love the maternal transport team." So thank you so much.
Thank you. I love you guys too.
Thank you so much for being here, Dr. Lewis, especially because I know you're in a different time zone right now. So we're extra grateful to have you here. Thank you for such an important discussion.
Absolutely. Thank you.
And with that, we are at the end of our presentation of our webinar, and I would actually like to transition over to our closing remarks, which will be given by Representative Donna Howard. And Representative Howard has served in the Texas House of Representatives since 2006. She currently serves as the Vice Chair of the Select Committee on Healthcare Reform and as the Chairwoman of the Texas Women's Health Caucus, which is the largest caucus in the country solely focused on advancing women's health policy. During her time in the legislature, Chair Howard has advocated to increase funding and access to women's health services and has fought against anti-abortion misinformation. Over the last year, she has worked to increase national awareness of the current state of women's health policy in Texas and the effect anti-abortion legislation has had in our communities. A native of Austin, Donna earned a bachelor's degree in nursing and a master's degree in health education from the University of Texas. She worked as a critical care nurse at Brackenridge and Seton hospitals and served as Austin's first hospital-based patient education coordinator. Donna is a past president of the Texas Nurses Association, District 5, and was a health education instructor at UT. And with that, I'll pass it on to Representative Howard.
Thank you. I appreciate it. I'm so glad I had an opportunity to hear most of today. It was very enlightening. I almost don't even know what to say anymore after all the things that were said today. So I'm going to, I am a politician. I am a person that's involved in the political process of policy making. And so I'm going to come from that slant, which is a little different than what you've been hearing today, but I think it's partially informed by the things that I heard today. I've actually kind of made different notes as y'all have gone along talking and altered what I thought I was going to talk about. So I think I just want to start off by saying that, clearly we're in some very challenging times here in Texas. And I'm talking politically right now. But that impacts what's happened, the kind of policies that are made. And just to give you an example of what I'm talking about, we have already lost, I'm probably about 20 people, maybe more at this point, through the primary elections and people who are not coming back, and more potentially could be lost in the general election. So we're coming back to a different legislative body, and one that's going to be much more conservative. We lost the chairwoman of the Public Health Committee. We lost the chairman of the subcommittee on appropriations dealing with funding of healthcare. These were two, both Republicans. I'm a Democrat. We are on very opposite sides of several issues, but also very, very committed to healthcare. And it's a real loss to not have those folks here. I'll mention J.C. Jatan, with appropriations was extremely helpful in allowing us to get more funding for women's health care that we might not have gotten otherwise. He was tremendous. And that's going to be a real loss as we have to rebuild these relationships and the knowledge base that's necessary for making those decisions. Obviously, we still have a lot of challenges with access to healthcare. You know, over half of the births in Texas are Medicaid paid for births. Over half of the counties in our state are maternal health care deserts. We know we've had huge numbers of rural hospitals close, at least close all the way down, but some of them closed their labor and delivery units. We did put some funding in this last time to try to help some of those hospitals stay open. We'll see how far that goes to really make a difference. But there's just a lot going on and a lot of politics that gets in the way sometimes of us making some really rational, informed decisions. And as much as we try to have those bipartisan efforts, and I've been in the legislature now for 18 and a half years as a Democrat in a minority party the whole time. So I don't do anything that's not bipartisan because there's no way I could pass anything with just Democrats. So, you know, clearly these are relationships that we work on and we try to develop and try to get informed decisions being made, but the politics just ultimately gets in the way a lot of times. So just a couple of other things about why it's challenging. Just even things like, and I know it's been mentioned several times today, talking about social determinants of health. We can't even say that. We can't use that terminology. That immediately turns off some of my colleagues who don't want to see that as a reality. And so we have these, what are they called now? Non-medical determinants of health, whatever. We figure out whatever we need to use and say, okay, that's fine. If that's the way you want to do it, then we'll do it that way so we can try to get something accomplished here, because that's really the purpose. But then also the other thing that I know has come up multiple times has to do with the disparities in healthcare, especially among Black women. And, you know, up until 2017, we did have an office of, I think it was called the Office of Disparities and Disproportionalities. But anyway, it was an office looking at minority health, and it was defunded in 2017 for no apparent reason that I've ever been able to determine. And we've had legislation session after session after that to try to reinstate that office, knowing how critical it is that people are paying attention and that they're at the table when we're discussing these policies. But we haven't been able to get that office back up and running. And you know, from all the discussion today, you can see it's critical that we have something like that and that we're actually looking at those things. We kind of have an overall hesitancy toward anything that deals with race right now. We've had the anti-DEI legislation at the colleges, and we're being told through the rumor mill now that there's going to be a similar effort at our state agencies to ensure that they aren't doing anything that indicates that they're looking at racial differences in whatever the services are that they provide. So that's a pretty thought, in my opinion. So all that being said, we actually did a few good things this last session for women's health care. You know, we talking about it in a post-Roe world, and I'm going to go negative again here for a second, but the horrific things that we're hearing about in terms of women going into sepsis because the physicians are unable to feel like they can intervene without possibly losing their license, having huge fines, and even going to prison for life. So it's not, this is a big deal we're talking about here, and we can clearly understand why physicians are having to be very, very careful about what they do here. But you know, we're having all of these horrific situations with women not getting the health care they need, and not until they are on deathbed. We took this. There were groups that took this to the Supreme Court of Texas, which of course punted it to the medical board, which has basically punted it back to the legislature for clarification. So that's still of major concern. But I bring that up to go into what was a somewhat positive thing. And that is there was a piece of legislation that Representative Ann Johnson from Houston was able to pass, providing an affirmative defense for abortions for ectopic pregnancies and premature rupture of membranes. So this is just one small part of what we would need to be looking at. But the fact is that that got through on a bipartisan basis. She was able to work across the aisle with some folks who helped that to come about. So because it's an affirmative defense, that means you have to be part of the legal system. So you're going to still be challenged, and it's not the ideal, but it was a step. And right now we're looking for any steps forward that we can take to make sure that women get the health care that they need and deserve. Representative Ardaz had legislation that provides for 12-month supply of contraceptives. This is huge, especially in a state with the rural populations that we have and the difficulty accessing care. To be able to get a full year supply is a leap forward. So that was great news. Also, Representative Ortega had legislation to provide for Medicaid reimbursement of community health workers, which again can make a big difference in helping navigate the system and get the support that's needed to access the health care and follow through with it, and all the things that those that are part of the community have the cultural competencies there can help make happen. And then, of course, the big one, Representative Tony Rose's legislation to provide for 12 months postpartum Medicaid coverage, which up until this point in time has been 2 months when you would be kicked off of the Medicaid program and have to find a different provider, perhaps a different system. So this was huge to finally get to that 12 months. And I'll tell you, that's been a long journey. Starting in 2015, there was legislation then to extend to 6 months. That didn't pass. And starting the next session and every session since, it's been looking at 12 months. But language got entered into the bill in 2017 using the term involuntary miscarriage, which was supposed to be language that says, okay, this doesn't apply if you've had an abortion. And that was purposefully done to try to get more folks to be able to vote for this. Still didn't make it, though. Finally, in the 2021 session, the House passed the 12 months postpartum. The Senate cut it back to 6 months, but kept that language in there of excluding involuntary miscarriage. And we never got approval from the feds, purportedly because it was excluding people rather than being available to everyone. Finally, though, this last session, we got the 12 months and got language changed so that the involuntary miscarriage was removed. There was a prelude, if you will, to the bill that basically says we value life. So there was some kind of cover there for those that wanted to make sure that this wasn't going to be seen as something to help anybody having an abortion. And I have to tell you, this is not really funny, but we kept talking about it like a Medicaid spa program, like somebody's really purposefully going to get pregnant, knowing that they're going to have an abortion just so they can get on Medicaid. That doesn't seem like really a likely scenario, but that's what the concern was. Bottom line is, though, it happened, it passed, it is now in place, and hallelujah, finally, women are getting the 12 months postpartum care that they need. So that was huge. That was probably the biggest thing we were able to do, and that was one of the speaker's priorities, as a matter of fact. Again, looking at how the politics works, we were able to leverage I think kind of the ill will that some of my colleagues were feeling after Dobbs and the overturning of Roe, because they were hearing from a lot of their women, Republican women too, saying, this has gone too far. There's no exceptions. We're seeing women who want their pregnancies, who desperately want them, not getting the medical care that they need because you have to wait till they start dying. So we were able to, I think, leverage some of that and had some of these successes this time, because I think my colleagues wanted to show, yes, we do support women, we do support babies, we do support families, and we're going to keep using that as much as we can as we go into the next section. Okay, let's see here. Oh, I wanted to talk for a minute about the MMMRC, because I think obviously that's been mentioned several times today already. And I know I saw earlier today that Dr. Scott was on this call, but I don't think she's on it right now. But of course, she's a newly appointed member to the committee. We did have legislation this last time that expanded the membership to include 3 more physicians, one from oncology, one from anesthesiology, and an ER doc. And then also added an additional community person, but changed the language so that instead of a community advocate, it was 2 community members who have some kind of healthcare related experience, one rural and one urban. And that's one of the positions that Dr. Scott was appointed to, which is, of course, San Antonio. And she's the rural representative, but she says that it's because she sees a lot of clients from rural areas. But anyway, that's the makeup of the committee now. And, you know, we have a lot of challenges with that review committee, one of which is that the last report we got, which we get them every other year, the last report we got in 2022 was 2019 data. The report that we're going to get this fall, this September 1, is 2020. We're nowhere near where we need to be in reviewing on a more timely basis what's happening with our maternal mortality and morbidity. One of the reasons given is that Texas is the only state, apparently, in the country that has to go through a very significant redaction process because of the Nurse Practice Act requiring the reporting by nurses of what they would come across in these cases that would be reportable behavior, despite the fact that that's not what the review is about. This is a review about looking at trends, looking at data, looking at how can we improve health. Every other state's been able to work with that. I had legislation this last time that would have clarified that the Board of Nursing signed off on, that we were going to be able to provide an exception for the review on this task force so that we would no longer have to do that redaction and the nurses wouldn't have to worry about their license. Got it passed in the House. It did not get through in the Senate. So that has still not happened. And I don't know what the specific time constraint is, but I can tell you that every time I talk with the people on the review committee, this is brought up as one of the main barriers to them being able to get more up to date on the review. So we're going to push for that again, of course, this next time and see if we can make that happen this go round. Yeah, when I think about it too, the report we're going to get this time, 2020, that's just when COVID is starting, basically. And it's before the fall of Roe. So really unrealistic here to think that we're going to be able to make policy that's addressing what's currently happening when we don't really even have the data anywhere near where it needs to be. But we do know from what we saw in the previous report and what we continue to be hearing from anything that's shared through the review committee is that we still are having a serious problem with maternal mortality, that 90% of the deaths are preventable, that the last report showed that 12%, they said 12% of the deaths, discrimination was a contributing factor in those. 27% are suicide and homicide, with the leading cause being firearms, also strangulation, but mainly firearms. So again, I know that the physicians for social responsibility, that gun issues are definitely a part of what you look at there. Certainly we have been looking at that and trying to work with the domestic violence folks to figure out what we can do to try to address this. It's just an extremely difficult situation in Texas where we don't have the kind of support for having what I consider to be common sense gun legislation that would ensure that those that are have intimate partner violence, that we are able to keep guns out of their hands. It's just horrific that this is even a factor. Already been talked about a bunch that hemorrhaging is the leading cause of death. One of the things that we did see is there was, I guess, a separate study done on an AIM bundle for hemorrhaging that showed that it did make a difference in terms of diminishing the severe complications of hemorrhage, except for Black moms. It increased, which is astounding when you're talking about actually implementing an AIM bundle that is really making a difference. How is it not making a difference? And actually, it's still worsening a situation for our Black moms. So I think, you know, everything I've been hearing today, we got to say this over and over again. We've got to address this, the implicit bias, whatever it is, it's there, it's real, and there's data here that shows that that's real. So that's a huge problem. Okay, I think I've kind of gone over most of the notes that I had on here. I really just, I know it's been mentioned by some, you all have a role to play in advocating for whatever particular aspects of maternal health care that you're focused on. But the fact is that, especially those of you that are physicians, you have a lot of clout. People respect your opinion. And even those of you that are students, your opinions are valid and respected and credible, and we need to hear from you. Whoever your elected representatives are need to hear from you about the things that you think we should be doing, the kinds of policies that we need to put in place. I mentioned the funding. You know, we significantly more funding this last go round than we had, but we go back to 2011 when, because of ideological issues, the funding for women's health care was cut by 2/3. Over 80 clinics across the state closed down. And it's not been an easy road to build those back up. You just don't decimate a safety net and then just resurrect it right away. So we've been building and building and building since then. We're probably back to where we were, but at the same time, our population has exploded. So we still have a long way to go to ensuring that everyone has access to healthcare that they need. One of the other things we did with the budget that was good is we got some more money into our federally qualified health centers. We got some mobile clinic funding with the help of Evelyn and her group. Thank you very much. You know, this is going to make a huge difference to get the care out to those folks who have a horrible track record of being able to access because of transportation, because of having to leave work, because of no childcare. The list goes on and on about why they can't get it. So having the mobile clinics that'll come to them. We were told about one of the first clients that was seen. They removed an IUD that had been in place for 13 years. And then another client, or several clients who had never, ever had a healthcare checkup before. This is what we're talking about here. We have huge challenges in this great big state. So anyway, the good, the bad, and the ugly here. I'm trying to be hopeful for next session with the big changes that I mentioned in terms of huge turnover in representatives, moving further to the right. Not sure what that's going to mean for what we're able to accomplish. We'll certainly be continuing to look at what we can do about providing exceptions for abortion healthcare. Despite the fact that there's a variety of opinions about that, I think it's incumbent upon us to get some clarity there and make sure that physicians know what they can do, how they can use their best medical judgment for the individual needs of their own patients. We also need to think about the rape and incest. Again, that's a huge issue. I know that the ITOP report that the state has that shows abortions, they significantly obviously went down. The reported abortions went down significantly from 55,000 a year, something like that, to a handful, basically. But when they were still being reported before Roe fell, I remember distinctly seeing in the statistics an 8-year-old. Okay, that child had an abortion, but that child at this point in time, at that 8-year-old at this point in time, got pregnant through rape, because that's the only way that could have happened. There would be no exception for an 8-year-old. This is just incomprehensible. Obviously, we want to keep working on access and what we can do there to make sure that we get more providers out there. I'm sorry, I've been told recently, I'm using terms other than provider. Are y'all? I was just made aware of this. I don't know if y'all are or not, but the term provider comes from Nazi Germany. It was a discriminating against Jewish doctors. I had no idea, but I was at a healthcare conference this week where it got brought up, and I looked it up, and that's the truth. That is where it comes from. So I'm trying to start changing to say healthcare practitioner, healthcare clinician. It's a huge thing. I mean, we all use that term all the time. And I was just totally unaware. So if you've not heard that before, look it up, because it's, anyway, it was, anyway, I'm not gonna go there anymore. Let me think if there's something else. I know we're running out of time here. I don't think I'm supposed to be opening for questions here because we're at the end of the time, but I just want to thank y'all so much for being a part of this, for making sure that you share this valuable information that I've heard today. It is so helpful. And it's really going to take all of us to get some things accomplished here. And I know certainly as a policymaker, I depend upon y'all to help me understand what the needs are, what we can do to help achieve better care for our moms and babies in the state, because ultimately that's what this is all about. So if there is anything else that you want me to say, or Yumna, if there's something you have you want to ask, whatever. So I know we have about 1 minute maybe.
I just want to let you know that the chat box is full of so much love and appreciation for you and the work that you do and the years that you have served everybody in this state, moms, kids, everybody. So I just want you to know that there's a lot of love here, and we are so grateful to have you. And thank you so much for taking the time.
Oh, thank you. I'm just so lucky to be able to do this. And thank y'all so much for being a part of this. I appreciate it.
And with that, I will go ahead and end today's webinar. I just wanted to say, on behalf of Texas Doctors for Social Responsibility and the Texas Patient Safety Initiative, and from the very bottom of my heart, I'd like to thank our speakers, our special guests, and everyone who attended today's webinar. A recording of the webinar is going to be available online. It's going to be sent to you within the next few days through email, along with information about CME credits. And just a reminder that everything that was shared today is not just meant to be informative, it is a call to action. Everyone has a role to play in this mission, whether it's through policy or practice or advocacy. And I cannot thank you enough for taking the time to be here, because this is engagement and this is a sign of dedication. And together, we can create a safer and healthier future for all mothers and all of their families in this state and far beyond. And I look forward to seeing y'all next year, I hope, and continuing this conversation in many avenues. And I am so grateful for absolutely everybody who's here today. Again, from the bottom of my heart, so much love and thanks to y'all. And I hope you have a fabulous Sunday.